Good evening. It's now 7 p.m. I'd like to start the meeting of Health and Wellbeing Overview and Scrutiny Committee. I'd like to remind everyone present that this meeting is being recorded. Also, I'd like to advise everyone that if we are speaking, use your microphones, but also make sure they're turned off so people on MS Teams can hear this afterwards. Thank you. Item 1, apologies for absence. I've received no apologies. Jenny, have you received any?
No, Chair. Thank you.
Item 2, I move that the minutes for the Health and Wellbeing Overview Scrutiny Committee held on the 1st September 2022 to be approved as a correct record. Does any member have any comments on the minutes? No, thank you. Item 3, urgent items of business. I have not agreed to any items of urgent business. Does anyone wish to raise any points on briefing notes? I don't think we've received any briefing notes at this point, so no. Item 4, declarations of interest. Does anyone wish to declare any declarations of interest?
Thank you, Chair. It's not a personal interest, but a standing interest that I work for the NHS. Thank you.
Items raised by Health Watch. Kim James, do you have any items you'd like to raise this evening?
If I may, Chair, there's a couple of items. Do you need to go back to Councillor Fish?
Yeah, sorry, Councillor Fish.
Yeah, just to say that I have a blue badge, so that might be of an interest on the agenda.
Thank you. Sorry, Kim James.
Thank you, Chair. Just to say, just for interest really, we've recently completed a piece of work that we were asked to do, every Health Watch nationally was asked to do it for a view, and it was around access to GP surgeries with various other things in there. We have now got our local report on that, so if I may, I'd like to share it, not today, but to have it circulated just for information. And also to say that we are going to start looking at following lots of issues raised with us from community around access to services, in so much as there's no community transport to speak of, and there is issues with the criteria for non-urgent ambulance. So we've had so many that we're now going to look into that. So I would invite anybody in the community that you're linking with that has that to let us know to add to our report. Thank you.
Thank you. Yeah, I think we may add that onto the work programme to come back in as a full report once you've got that work and done some work. I'd like to pass my personal thanks to you for the work you've done recently on a number of cases with local residents, and it's been very helpful, so thank you. Item 6, community inpatient beds in Mid and South Essex. Can I ask James Wilson via MS Teams to present this item, please?
Thank you, Chair. So my name's James Wilson. I'm Director of Transformation for the Community Collaborative in Mid and South Essex. So that's where we've brought the 3 organisations who deliver community care for our residents, NELFT, EPUT and Provide, together to collaborate to see how we can improve the delivery of community services across Mid and South Essex. So the paper that we've got on your agenda tonight is a short update on progress, as we committed to bring you regular updates on the work that we first presented back in November 21 around the options we were exploring around the configuration and location of our community rehabilitation beds. So that's both beds for people who have a stroke rehabilitation need and a non-stroke need. The rationale for why we started that piece of work, which we ran through with the committee previously, was that we wanted to ensure we've got a consistent delivery model that really ties in with those local pathways and ensures that we've got, you know, that great pathway out into people's own homes as quickly as possible, and recognising there's some new delivery models that are emerging, things like virtual wards. Also, recognition that our stroke provision, when we compare that to the national benchmarks, that there's opportunity to improve that further and look at making sure we've got the right capacity and making sure we're meeting the new national stroke specification for that rehab in people's own homes. In a community bed-based setting that complements the rehab that we do in people's own homes. And the third, and it was a real catalyst for picking up this piece of work was during COVID, we had changed a number of the locations of our community and stroke rehabilitation bed-based settings out of need to consolidate to meet the requirements of COVID. And we wanted to engage with stakeholders around whether the current configuration that we'd moved to during COVID, whether that made sense, or what were the other options that would make both sense to ensure we can serve the population moving forward. So that was the real drive, and we committed to then starting to do some early engagement work with a potential consultation on that future configuration and bed model. And the report highlights the progress made. So it talks about the bed modelling that's been done. So we've got a really good idea of what's the right quantum of community beds that are needed across the Mid and South Essex geography. We dug into travel time. So what's it going to mean for people to travel to different facilities, and what would be the impact of any potential configuration options. We took a detailed review of the estate. It's worth reminding the committee the kind of scope of this was the NHS intermediate care beds, so that the estate was the NHS estate that's been provided there. And we undertake some work with our clinical teams to look at what would be the optimum model of delivery for our rehabilitation services. And we took that proposal to the East of England Clinical Senate, which is an external group of clinicians from outside of the area to test our thinking around what would be the most appropriate clinical model. And that was broadly supported with a few minor recommendations on what would make sense for the future. We also undertook some pre-consultation work. So this is pre any formal consultation to understand what was important to stakeholders, to users of the services, to inform what would be the approach to wider engagement and making sure that we got that approach right if we went to formal consultation. The paper then goes on to highlight really the current position. So since we embarked on that piece of work, there's been continued an exacerbation of pressure within the NHS. And that's meant that there's been some more recent guidance that's really focused the mind in terms of making sure that we maximise any bed-based settings that we've got to ensure we can meet the demands that are facing us over the winter period. So that's meant the team's diverted some of its attention is considering options for a couple of the sites that were closed during the COVID period, Mount Nessing and Housestead wards, to see if actually there can be a quicker solution to open some of those wards back up again. And as part of that, the team is still then committed to then considering what's the optimum location for our stroke provision. And that may mean that we come back to this committee in the future in terms of a formal consultation around that. But the immediate work around the reopening of the two of the sites that were closed previously during the COVID period is the main focus of the team. And so a kind of pause to the potential wider options for the longer term future while we focus on the immediate term. And then we'll be coming back to the committee about views around potential engagement and or consultation for that longer term configuration. I think it's really important to emphasise to this committee and Thurrock residents that Mayfield hasn't changed during this period. So it's always been an intermediate care facility and is still open, and is still the intention for that to remain open. So it's just to make sure that this committee is up to speed on the wider developments across the wider Mid and South Essex geography. Thank you, Chair. That's it from me.
Thank you, James, for your report. Does any other members have any questions? Councillor Apothecary.
Thank you, Chair, and thank you, James. I just wanted to ask a quick question about the Stroke Rehabilitation Centre. I feel you may have chosen your words quite carefully on that. Is there a chance that under that consultation we would see a proposal for stroke rehabilitation to be concentrated away from Thurrock, essentially? So there seems to be a trend to having centres that are less local, less embedded in the local community and further away. There's an argument around specialisation of care, etc. But I'm just wondering, in this consultation, would we be looking at fewer centres, fewer larger centres, if that makes sense, further away from where people actually live?
Thank you for the question. So the current configuration of the stroke community rehabilitation is we've got 2 sites across Mid and South Essex. So one is in Rochford in the Cumberland centre there, known as KIC, and the second is in St Peter's in Malden area. The current thinking of the team and the work done to date looks like an option, certainly the preferred option, albeit this is subject to the next phase of work once we'd come back to the committee with the firm options around this, is that we would probably require 2 sites that would increase the overall volume of stroke rehabilitation beds slightly from our current position. And though we would probably be looking for a site in the kind of north and a site in the south as a preference. So that shouldn't significantly change for Thurrock residents any point of access currently. But we will come back to the committee in due course when we firm up any proposals around stroke rehabilitation.
So, sorry, so just to quickly confirm, at the moment, Thurrock residents who are doing stroke rehabilitation are going to Rochford at the moment?
They go to that, and they have always done, unless it's appropriate for them to get their stroke rehabilitation in their own homes. There's an early supported discharge team who provides that stroke care for people in their own home. So that service hasn't changed for a number of years. So that's the existing arrangements.
Okay, thank you, James.
Kim James.
Thank you, Chair. James, can I just ask you, point 3, where you've got your progress to date, there's a lot of things in there. Will we get sight of the outcome of those? Because you've got a detailed bed modelling and various things. You also in here, it says that the initial pre-consultation engagement with patients was brought to the committee at his meeting on the 1st of September. I've looked for those, and in fact, it was deferred to here because it says that this item has been postponed to the next meeting. So I haven't seen that, whatever it was that you presented on the 1st of September, or am I missing something?
Unfortunately, so a paper I think was submitted then, but there was that wasn't formally presented. So I'm happy to share those documents again if that's helpful. So that will be the pre-consultation engagement report that was done at the time. The bed modelling will inform a future paper to this committee around the options that would be considered for any consultation. So that would be the appropriate point to bring that detail back to this committee.
Okay, thank you.
Yeah, thank you, James. Yeah, because the what happened at the last meeting, where it was failed to be presented, a lot of the information was missed that we didn't get, and I was expecting that full report to be brought back today, but it's not. I did ask if this had been edited down, because I did notice there's some information on the last report that wasn't actually in this, because I think the last report had something like 20 odd pages in it, and this has like got 2. So if we could have that back out, it was a lot more detailed with the plans going forward. Even if it's just shared it back out to members again. One of the things, obviously, we're under a lot of pressure at the moment with discharge from hospitals. With services sort of potentially moving to a new site, would that mean closure of, say, the Rochford facility? Could, as Councillor Pothcoe pointed out, could we see maybe something open up in, say, Bishop Stortford or something like that, where our residents have to go even further for recovery?
I think one of the key themes that was really important that was fed back about that pre-consultation exercise was around the importance of local facilities where that makes sense, and the current immediate plans that are happening in terms of the winter response to make sure we reopen the capacity that's not in existence means we've got more local capacity opening. And at the moment, I think the longer term, that theme of ensuring we have local provision where that makes sense will continue. So I hope when the committee sees the kind of final options coming back in the future will mean that there'll be an ongoing local facilities, that the geography you just mentioned there, the Bishop Stortford, that's not something that's currently planned, and there's no active plans currently to close or the Cumberledge Centre in Rochford at all, and that's a key part of the estate and one of the key areas we'd want to be maximising in the future.
Brilliant, thank you, James. So the recommendations on this is to note the report and agree to receive detailed proposals of any potential public consultation in the future. Yeah, I think that'd be great if we do that. We'd definitely like to, before it goes out into other consultations, we'd like to see heads up on that. So thank you for the report, James.
Thank you.
Yes, James, if you wish, you can leave the meeting if you want to.
Super, thank you.
Thank you. Item 7, under doctrine in Thurrock. Can I ask Stephen Porter via MS Teams to present this item, please?
Thank you, Chair. I'll just get the presentation slides up. Okay, can everybody see that there?
We can, Stephen, thank you.
I sent a copy out as well. So this is about under-doctoring in Thurrock. I don't think there's no contention about the fact there is under-doctoring in Thurrock. We absolutely know that. For example, if you look at some of the stats from around England, you can see that Thurrock is second only to Portsmouth in terms of the fewest GPs to 100,000 people of the population. So I mean, it's clearly not adequate, and obviously results in more difficulty accessing GPs, potentially longer waiting times for appointments, and other things which we know about. So it's not a good position at the moment. So it's a bit of a postcode lottery, and some areas have got half the number of doctors as others. There are a few there that you can probably see have very few. Some have many more. And Wirral, not too far from where I am at the moment, they've actually got double what Thurrock has got, and there's no rhyme or reason for that. And absolutely there should be more equity, we believe, in the system. So it's not a good position at the moment. What does it mean? Well, in fact, just taking one of the examples from the GP patient survey, which came out a couple of months ago, national responses in terms of the ease of getting through by phone to GPs. So we looked nationally at this, and we looked at what our ICS at MSc. We don't have it at Alliance level, but we've got it at ICS level, and we can assume Thurrock is something like akin to that, possibly. They would probably have a lower figure for themselves. But nationally, in terms of people saying it's easy, 53% said it was. In Thurrock, in the ICS, it's only 41%. Similarly, not easy. Nationally, 47% people said it wasn't easy, whereas in the ICS across mid-South Essex, it was 59%. So clearly, that's playing out in terms of people's experience, which is not a good picture. The reasons, one of the overarching reasons is GP contracts are not with MSE. They're not local. They are predominantly with NHS England, and they are basically that GPs are in fact small businesses, and they cannot be compelled to work anywhere. So we've got these variations in ratios of patients to clinicians, and in the most deprived areas where you're going to get probably people with much higher, more complex needs caused by lifestyle issues and deprivation, like smoking and obesity, that is very unhelpful. So this is not a reflection of individual practices, but it is, as I've said, the result of the way primary care has traditionally been funded and still is. And we're not helped in Thurrock and in the home counties by the staffing pressures that we've got in terms of the age profile of GPs. They tend to be older, but also a proximity to London, that you know, GPs can earn a London waiting if they go what is in effect a few miles down the road, although I think personally the M25 isn't worth it. But it's still a factor that made people bear in mind when they choose where to work. So what's the response? There's been a national and a more local response, and the local response is probably what I want to focus on more a bit later. But some of the headlines, I guess, from that, Health Watch England have asked the government to address this issue. Obviously, the government's been fairly preoccupied recently with other things, but this is a very important one, and I'm hoping that Health Watch England will continue the pressure to do that in terms of making the NHS England and the government aware of this issue from their perspective. Some things, though, that are potentially positive. We've got a medical school at the ARU in Chelmsford, and we're hoping that means that people who train in Essex and probably live in Essex will train as doctors and work in Essex. Locally, and the council's been very instrumental in this, we've got a 13-point action plan to transform primary care networks. This has come from the Thurrock joint strategy, Better Together, the case for further change. And as I say, the council has been very strong in helping to deliver. So this is about reducing pressure on GPs by looking at other supports that could be around. So GPs are important, they've got a massively important role, but sometimes when it's prevention and early intervention, before people need to see a GP, there may be things that other services can do. And we know that people sometimes go to a GP and actually it's not necessarily the physical illness that's making them go. Sometimes people are actually lonely, they're isolated, they don't have any money, they're having in very difficult relationships at home. It might be a housing issue. There may be all sorts of things there that we can help to take some of the pressure off there. And Thurrock particularly is noted for its local area coordination service, which is very much about making those connections and getting that early intervention in as soon as possible. We are investing in additional capacity through the additional roles reimbursement scheme, the ARS roles. So these are additional roles that are in and around and support GPs, and I'll come on to those in a little more detail. You see what I mean shortly. So we've got 40 working time staff now in place, and we're going to double that. The plans are to double that to 80 by 2024. And we're stretching the definitions of what that could be to the limit. We're being creative around attracting people and providing opportunity, and I'll come on to that in a moment too. But also, but this is for the longer term, this one, investing in GP apprenticeships with Anglia Ruskin University, and that will bear fruit over the longer term. And Corringham IMWC opened today, which was fantastic news, and Tiffany will say more about that a bit later. But for that, we are recruiting 12 GP fellows to work from the Corringham base. That campaign is live now, and they will be working from there, but they will also do outreach to other parts of the local system. So the R's roles are there. You can see the type of roles I'm referring to. So social prescribers, pharmacists, first contact physios, paramedics, care coordinators, physician associates, trainee nurse associates, and advanced practitioners. These are not taking the place of GPs, but they can prevent some of the pressure building up on GPs if they're able, in a qualified way, to deal with the presenting issues that are there. And Corringham is a good example of how that will come into play, because it is truly joined up. It's going to be a wraparound service, people co-located from a range of professions who should be, you know, what we're trying to do is cut out red tape and make referrals and access much easier in there. So that's the shape of things to come, with 3 IMWCs still to open in the next couple of years. So we've also got a training hub, and this is central to our offer to try and attract these GPs around workforce planning and embed them into new roles with those R's roles as well. We're offering, obviously, support with continuing professional development, career support at all stages, and I'll say a little more on that in a minute, and support for new GP partners through a tailored development programme. So that will look at all things developmental and all things training as well. So what we have are some very specific initiatives. Now, I won't read all of these out, but I'll give you a flavour of what we're trying to deliver. So we've got continual professional development. This is quite small even for me to read, I've got to say, to remember it all. Continuous professional development, and this will sort of support GPs. For example, if some of them wanted to go off and become part-time lecturers at the university, we will see how we can support them to do that with the right training and support around them. We will also look at people who want to specialise in particular areas. So there may be GPs in terms of general practice, but there may be things that we can do as a system that will put supports in to enable them to specialise on certain subjects, such as at Corringham, we've got the obesity pilot because we've got a very good clinician who's our assistant, who's our clinical director for Thurrock, who has some expertise in that, and that's the expertise we want to bring into Thurrock and we want to grow. So lots of stuff around development, training opportunities, diversification and career pathways, whilst retaining a core working practice in Thurrock. So anyone wants to contact the, find out a bit more about that, there's an email address there, and we will be putting that on the website, our website, fairly soon. But what does this all mean, and what do we want to do at the end of the day? It's not just about getting, you know, bums on seats, so to speak. What we want to do is we want to deliver improved access for patients at the end of the day. So we've got a plan for patients, and the access to GP appointments is tantamount in that. So people should be able to get an appointment within 2 weeks, but if people who need an urgent appointment should be seen on the same day. And we're going to start to publish the appointment data on a practice level from this month, so be able to see what that means. We are going to put in an additional 31,000 phone lines to make it easier for people to contact their practice, then that's by March next year. And we're going to also make more time for patient appointments by introducing digital tools and improve IT systems to ease administrative burdens. Also for people to access appointments, not just by the phone. Many people can't do that. We appreciate that. And older people in particular aren't as IT literate, but it's having a raft of opportunities or a raft of approaches for people to be able to do that, where the telephone will still be there. And also reformation of the R's roles, the ones I referred to earlier, to broaden the criteria and the range of roles that are available there. So in terms of local implementation, for example, what's happening now, we've got a new inter-access scheme, which is a provision for longer consultation for people with complex patients. So not sort of just in and out with one issue. Some people, and we know for a fact men in general actually save up their illnesses and go, because they don't like going to the doctor, so they save a few up and then they go in, and then of course, you know, they want more time to talk about them all. So with people with complex needs, and we'll have more time to talk about those in surgeries. The telephony solution I have mentioned by March 23, and a new signposting program as well to look at alternative practice pathways to GPs and practice nurses. So there's quite a few things there. As I say, I won't read them all, but you've got them. If there's any questions, I'll answer them. I'll try and answer them. So that's about the website and supporting PCNs with digital transformation. So that's also supporting the individual GP surgeries with telephony and access to IT and other things. Although these are their own businesses, I think we've got a role to play in trying to support them to get the best out of their work for patients. There's some national guidance that's going to be coming out, we think in the new year as well, showing about in regard to one, I think is the telephony framework is coming out, but we want to connect there's an issue also about pension rules which may prohibit this is way beyond my sort of knowledge really, but there is an issue around pension rules which does mitigate against some GPs working full-time or beyond their hours, and that's an issue also we are taking a look at with through NHS England. So what we will do is we will We've got this plan for patients, a local implementation. So we're looking at triage as well and how that works. And we need to sort of move from a sort of administrative role where people are picking the phone up, and then patients understandably feel concerned about sharing their issues, their health issues with what they foresee as a receptionist. But we're changing those roles into care navigators. We've basically got more skills to be able to ensure that people get the right response from the right person at the right time. And that also includes alternative dispositions, like it may be an issue for pharmacy. We all know that people sometimes phone up even 999 if they've got a cold or a bad cough, when actually what they probably need is a trip down to Boots and to get some Lemsips or something along akin to that. I'm not downplaying the fact that people do sometimes have serious illnesses and do need to speak to a GP, but we do know that the other end of things, that actually happens, and we do see it from time to time. So again, IT and bookable appointments on apps and websites, we're looking at that. And enabling the ICS to support communications and engagement with patients for new approaches to front door pathway for primary care. So that's pretty much it, Chair. Take any questions or comments people may have.
Thank you, Stephen. I do have a number of points. First of all, with the Coronum IMC, the 12 fellowship GPs, I know that's a live rollout at the moment. Do we have a number of the GPs that are currently engaged in that programme?
My understanding, and Tiffany's on here as well, you saying GPs that are already at Corringham? Or are you saying how many?
Yeah, how many GPs are currently ready to go or in the pipeline to go at the Coronum IMC, the fellowship GP?
Tiffany to answer that if she's able to. I don't have that figure.
Yes, I can give an update. So the latest update is we've got 6 of the 12 posts with people interested in them. None have started. It does take time to go through the pipeline, but we do anticipate a couple starting very soon. We had a fabulous meeting in Basildon with a team that really sold this concept. They did a fabulous job. We're about to do the same with some local GP trainees in Southend, I believe. So we're hoping to get more take from there. The real message that we gave was that you tell us what you would like out of your career and we'll help you to achieve it. We'll help you to do the 2 parts, to be the GP and to also take on something else, some other part of medicine or some other area that you're really interested in. So, for example, we've got someone that's interested in medical IT, which will be fantastic for us at the time that we're looking to bring in electronic patient records across the system. So we can work with them exactly what they want, and that's extremely attractive for some of these newly qualifying GPs.
Thank you, Tiffany. Stephen, you said about making accessible the data on appointments. How many appointments are being made? What slide it was actually on there? Will those appointments actually be physical or phone call appointments that you'll be recording?
I think that's a very good question, actually, and I honestly don't know. I think it would make sense if we recorded both, because obviously we understood why the virtual appointments came in and phone appointments for COVID, but actually, and it's hard to say, we can't say COVID's over either, because we know it's spiking again. We don't have the same data that we had previously. I don't know. I can find out. There may be other people in the room that do know that. I can certainly find that out for you, Councillor Ralph, and I will email you with the answer.
Thank you, Stephen. Yeah, if you could email me and I'll share it with the rest of the committee. Obviously, it does bring a level of concern. As a councillor, we get contacted by residents saying they can't get hold of their GP, or their GP, they've got a concern about a rash or something on their body, and they're put on a telephone call. And this leads to things maybe being missed. And so I really do feel that we still need to push back to physical appointments. I know you said about a cough, and it may be go to a pharmacy and get it, but let's not forget you can't beat a doctor listening to your chest with a stethoscope to actually find out what's going wrong and then recommending an x-ray. We need to get back onto that. Too many people are being misdiagnosed. That is why we need to take the pressure off the NHS and A&E. people are using A&E as a doctor's. And there's no argument with that, because we can't, you know, and the poor A&E service is just surrounded by it. And that's because people have lost confidence for the doctors. They want to get into a physical meeting with a GP to go over their concern. And that brings up the next question, the 30,000 phone line connections that's been made available.
Yeah.
31,000. I'm guessing that's going to go to a call centre then, not the actual GP practice.
Not my understanding. I don't think so. It's basically looking at digital solutions and cloud-based telephony. So it's using the internet to sort of manage it. I am not an expert in IT by any stretch of the imagination. I've not heard the word call centre being mentioned, and it's not my understanding whatsoever. It's about a local response, and it's about using the technology to be able to extend the capabilities of what we currently have. That's my understanding of it. Again, if you wish me to find out a little bit more about that, I will come back to you. I'll drop you a line. But I'm not an IT expert, but absolutely not my understanding of that at all.
Thank you. Councillor Puffcarry.
Thank you, Chair, and thank you, Stephen. I just wanted to follow up on Councillor Ralph's point about the telephone appointments, which is that you know, sometimes a telephone appointment might be fine and adequate and suitable. What I found with my GP is that I can't get a face-to-face appointment. We have to go through a telephone appointment first, which is essentially a method of triage, it seems, and kind of adds a 2-week delay to getting seen. Those telephone appointments, though, are not scheduled. So, for example, a couple of weeks ago, I was told I needed an appointment for my daughter, who is 10 and at school. I was told the doctor might ring you any time between 8 in the morning and 6 p.m. at night. Now, I work, I have a job, I have a toddler, I have a 10-year-old daughter who happens to go to school between 9 and 3. There was 1 hour on that day that I could not answer the phone. Guess which hour during which the doctor called, because that's the way these things work. But my daughter wasn't even with me. So even if I had answered, I would have had to have spoken sort of on behalf of my daughter. I couldn't have checked things with her. I couldn't have asked her any questions. And I had pointed this out to the receptionist when she made the telephone call. I said, if you call me between 9 and 3, my daughter will be at school. So I'm just wondering about the telephony issue. I'm not entirely convinced the answer is a technological solution around more phone lines. I think it's actually around sorting out appointments so that we can actually get through. The other problem with the phone system, and I think actually the data you've got here on not being able to get through might be slightly misleading in this sense. I think actually the big problem people have is with the 8 a.m. lottery. You know, if you can't ring at 8 a.m, I can't ring at 8 a.m. ever because I'm on a train going to work at that time. You know, and I don't want to, and then I have to tell the receptionist what's wrong in front of a train carriage. So if you call at 8:15, 8:15, by that point you're told, no, you should have rung at 8, we can't do anything, you'll have to just call back another day. So I think that there are lots of issues to do with capacity there that don't have those necessarily technological solutions, but actually we just need to iron out making sure that we have a better system for being able to book appointments.
Okay, I absolutely take your point, and I think I've had a conversation with Kim from Health Watch about this as well. I share your, I mean, we've all been in that position you've described, I think, and people call, they call you at the most inconvenient time. I mean, it's something we'll continue to work with our clinical directors on, and our, in the PCNs. I will continue to push for that issue to be acknowledged and resolved a bit more. We can certainly do something more about that. I think we can hopefully win those GPs round in terms of the compelling argument that what might be convenient for them, and they have to manage a relatively complex business and all the rest of it, but actually we've got lives as well, and we need to be not only, as Councillor Ralph pointed out, there's certain conditions which would benefit from scrutiny with a pair of eyes, but also in terms of the response time coming back with phone calls, it's not always convenient for us when they do call back. I will take it forward to our clinical directors. We meet with them on a regular basis. I'll put that on the next agenda for a conversation there, and hopefully I'll be able to sort of come back to you with some kind of update at the next one, or myself or a colleague will do that. but it's a point well made. Tiffany's just put some clarification of the telephony programme in the chat, Councillor Ralph, and I can't really add to that other than it, you know, that was my understanding. It's cloud based. Sorry, I'll stop there.
Okay, thank you. I don't know what was said in the chat.
I'll read it to you. The primary care telephony programme will enhance telephony services of primary care practices with agreement to fund 25 practices across MSE in the first phase of this programme. The telephony will be cloud-based, increasing the number of lines in and out of the practice, as well as services such as call waiting.
Thank you for that clarification. Councillor Fish.
Yeah, I've got a point to make about the ease of getting through on the phone. I think I've mentioned it as well, but you've chosen to go with categories of easy and not easy. There's not enough information there because it depends on the time of day. If you phone at, say, 11:30 in the morning, you'll say it's easy because you'll probably get through straight away. As Councillor Apothecary said, if you phone it first thing in the morning, it's very, very difficult. So I think that if you're going to look at a realistic picture, it's probably actually, for most people, it's much harder than just to say 59%. I think it's probably higher than that. And then...
Point taken. Sorry.
Yeah, go on.
I was going to say point taken, absolutely. That's from a national survey, though, so we didn't have any control over the level of granularity of the questions. It's certainly feedback we can give when we're asked to comment on it. But you're absolutely right. Obviously, you know, that's quite simplistic. I think I'm just giving a broad measure of how people, you know, their experience is, and it takes, you know, the full range of experiences. As you say, you know, I imagine there are people who would be less favourably commenting on that, and I imagine, you know, Thurrock across Essex would be more likely to be quite negative about it, given the ratio of GPs that we have. I can certainly feedback about the level of detail in the survey, but it wasn't ours. I think that's come out from NHS England.
So another point is about social prescribers. I think they're a fantastic innovation into surgeries, but it depends how they work, because if they're given an hour to work with each patient, they can make a real difference. But if they're working along the same lines as GPs, and have very short time to work with each patient, they're not going to be as successful. So what model are we talking about them working to?
I don't think they're working to the same constraints that GPs are under by any stretch of the imagination. I think they're much more flexible in terms of their time. And, you know, I think they can work both in a prescribed way with appointment times, and they can work also without set appointment times. They can hold, you know, walk-in sessions, and they're much more flexible in how they work. They're not constrained by like GPs are with time. I think they'll be able to give a much more, you know, more time to people depending on what their needs actually are. And of course, what the other thing they can do is they can also refer on to housing or to social care or any other services that they think are appropriate. So I think it's probably a good model, but obviously, like everything else, we will keep a very close eye on it to make sure that it fits the needs of what we're trying to do in Thurrock.
A final point, when it talks about the additional roles reimbursement scheme, and it lists pharmacists and social prescribers, physios, paramedics, care coordinators, all of those roles are being carried out at the surgery that I am with, and it still takes 2 weeks to see the doctor.
I think the obviously there's a triage, there's a filtering process that will go on. There will be some people that might not get to see a doctor because they actually don't need to, and they're quite happy with that response. Certainly there will be some that felt that maybe they should have seen a doctor and they didn't get to see one, or they didn't get to see one in time. And that's really important to note as well. And it's why having a health watch around and, you know, having an ear to the ground, really, to hear those experiences is important, so that we can then go back to the surgeries, liaise with the clinical directors, liaise with the practice managers, and draw these individual issues, you know, or even beyond that, wider group issues out. You make a very good point, but I do think that also we don't sometimes know that, and because it's almost like, well, if they need to be met by some of these other professionals, then we wouldn't necessarily get to know about it. But we do, you know, it doesn't show up in in the figures for, the national survey, for example. But again, your point is well made, and it's something we will absolutely consider when we speak to the CDs and the practice leads.
Okay, thank you for that question, Councillor Fish. Councillor Polly.
Thank you very much, Chair. I'm afraid I've also got a list of questions. So, sorry, I didn't quite catch when we did the working time, the WTE, what does the E stand for?
Equivalent.
Okay. The additional roles and reimbursement scheme, we haven't just magicked up 30 paramedics. I would say they've been poached from another service. And I think one of the reasons that the GP surgeries are attractive are because of the working hours. Paramedics on front line are 24/7, 365. Bank holidays, Christmas days, if you're a younger person who's got family commitments, or a person who's been in the service for a very long time, who's done many years of shift work, those are quite attractive. So we're sort of pinching from Peter to pay Paul on that. We're not creating new paramedics. We're just taking them out of service. That then leads me on to all of these new initiatives. They still work within the confines of a Monday to Friday, 8 till 4 restraint, really. We've said that they're run GP surgeries that are small businesses, effectively. Some of them quite large businesses. I don't know of any business that would shut their business down every first Tuesday of the month to do training. That's a luxury a lot of other professions do not have, and I would suggest even our colleagues here within the council, not just I do clinical personal development. We have colleagues here that do professional personal development. We don't shut the council down to have a training day. We don't shut down a hospital to have a training day. So given that there is such a national shortage of appointments, if we're losing one day every month for each surgery in Thurrock for training, I think that is a disservice to our residents.
Shall I come back? So that's certainly one way of looking at it. I think there's a two-edged sword, really. If I was a practitioner coming into Thurrock, I'd want to be attracted by the fact that I could get some training every month. And that doesn't, the way the clinical practice evolves and changes, new research, new ways of doing things. NHS England, who hold the contracts, are very, very demanding in terms of what they expect. So even just keeping up to date with what NHS England want is, you can't do that on the job all the time. You have to stop and pause. So that's one way of looking at it. I can also think of an argument where you'd want your medical staff to have these regular training so they're up to date, current, know the latest, what's going on with medicine and information like that. So I think it's a two-edged sword. It does attract people as well. If Thurrock says we're able to, and we can't, to our GPs, well, no, you can't have any training. So where would they go then? They probably, they go off elsewhere. They go to Kent or somewhere else. So we have to sort of find the right balance, I think, is what you're trying to say. And I think we will continue to push for that. And I think in terms of the paramedics being poached, like everything, it's a free market. People are entitled to work where they are. There's no intention deliberately to poach at anybody, including paramedics. But the world of work is that people will go where they think their opportunities are, which suits their childcare commitments, their caring relationships, and other things. So it's quite a complex issue. But I do think, what we'd like to see is more trained paramedics in the system, so that there's enough to go around. And I really do take that point.
Sorry, if I can just come back on that, I wasn't suggesting for 1 minute that our healthcare professionals do not keep their training up to date.
I take your point.
we don't
Obviously,
shut the ambulance service down, we don't shut the A&E department down, we don't shut the hospital down, but every one of those people working within that area are up to the minute with all of their professional updates.
I take your point, and I don't know enough about the detail. I mean, you know, I can't speak on behalf of every single practice. They may not all may do things slightly differently, but I do take your point, and it's not ideal.
Yeah, sorry, Steve. I'm just going to bring in is it Dr. Fenton.
Thank you, Chair, and thank you. I have found listening to this conversation really interesting. What's played out is the reality on all sides of this problem, and the reality is, as Kim has pointed out and will probably point out in your report, because I read the one for I think Southend or Essex yesterday, our residents, both in Thurrock and everywhere, are finding access to GP practices really, really difficult. And my colleague has described the issue with GP numbers, very low in Thurrock, probably the lowest in the country, but that is a common problem around our ICS. And there is no bus with GPs coming down the A12 anytime soon, but the things we're doing, as described, the 12 apprentices, 6 at present, hopefully 12 will help, the 100 doctors who will actually graduate this year from our university in Chelmsford, which is there for exactly this problem. All of these are going to help, but they won't totally solve, because hence coming at it from all the directions. The R's roles are exactly that point, that they're in order to provide a route for patients to see people who are qualified to see them and take the burden off our hard-pressed GPs. We have the R's roles in place. I don't think they're being used efficiently or well by our GP services across our system, and I have that conversation regularly with our PCNs, not just in Thurrock. There is a real opportunity there to remove a burden on our GPs. You're correct about paramedics. They're a hugely valuable resource, as are all the R's roles. Subjectively, the paramedics I know who do these roles, they really like to do the roles for exactly the reason you described. Being on the road is a really hard job. They also like to keep their opportunity to be paramedics up as well, so they do go back into the service. And perhaps what we will find is we will keep them doing both things for longer. Time will tell. In respect to the telephony is not the panacea to everything. We do hope it's a cloud-based system. What it will do, hopefully, is remove this 8 a.m. culture that you've got to ring, because it will provide reassurance that you will be heard and you will be in a queue and you don't have to do it 8 a.m. on the dot. But it's only part of what might improve the offer we provide our residents. You may be aware of the Fuller report, which is a report by Claire Fuller, Professor Fuller, looking at GP offers entirely, and we're very much trying to make that happen across our system. And essentially there are 3 aspects. If you need urgent care on the day, it actually doesn't matter who you meet. You might know Dr. Fenton personally, but actually if you need care for your daughter, you need a doctor. And there's a system, we're trying to bring systems into PCNs where they share that urgent need across their practices so that you get the access that your daughter needs on time. The other thing is that we all know that we fully value the relationship we have, especially for chronic conditions, with our individual doctor. Doing that for urgent care, having the hours roles, we hope frees up the doctor with whom you have a relationship, and that's important, so that you can see that individual doctor for your long-term condition. So, and then there is the other third part of the full report is about prevention, but we won't go into that. You are right, it is hard to comprehend how a practice can close down. I believe time to learn is half a day rather than a day, but nevertheless it's a quantum of time that the doors are shut. The emergency access is still covered at that time by IC24, so that there is that there, but your regular appointments are not available. I would point out that in the hospital it is mirrored by a monthly, what we call an audit day, which occurs every month, half a day. Everything except the emergency provision stops. Where that started actually was when we realised that we weren't learning from each other, and what was called CPOD began, the Confidential Inquiry into Perioperative Deaths, back in 1989, I think it was. And it suggested that we actually stop, think, and listen and learn from each other. But to do that, you do have to stop something. And I can see that the tension about whether it's right or wrong, but that's why it's there. So I'm really grateful to have heard everybody's view here. You have unfortunately reinforced my own view, and I think what will come from Kim's paper as well. We're not in a great place at present, but we're desperately trying to get to a far better place, because we are all patients, we're all residents, and we all need it.
Thank you, Doctor. Very valuable input. Thank you for that. Just the last question, Councillor Piccolo.
Thank you, Chair. It's not so much a question. I must be very fortunate. I'm astounded by what I've been hearing here this evening. I'm not saying, when I say astounded, only because of my personal experience with my personal GP. If I phone up at 8 o'clock in the morning, I get the choice of whether I want a call back or an appointment that day. The call back is between, they tell you what time it's going to be, so it might be between 12 and 2 or 11 and 1. I don't know whether or not other surgeons have thought of limiting that callback time. So I say, whilst I appreciate the doom and gloom around Thurrock, I'm hearing it tonight. I really appreciate my local doctor's surgery. Yeah, I'm not going to tell you which surgery I go to. But no, I just thought I'd like to sort of lighten the mood a bit, in that there are cases where the doctor's surgery does seem to try and overcome these problems. I think it's ridiculous waiting between 9 and 6 for a phone call. Anyway, that was all I wanted to say, Chair.
Thank you, Councillor. It's a very interesting point as well, that one thing we should note is our GPs, on the whole, do the best they can. We are in unique times and been through a unique situation. What I would ask is, one thing, could GPs please change their answer phone messages? Because many times you phone up, says, due to, we're following the current COVID restrictions by the government. We not got those restrictions in place. That is what makes me feel they're still using it as an excuse not to see face to face. Yeah. Yeah, in the clinical profession, I understand that side of it, but I do feel that they use it as a tool to avoid the face-to-face contact. I do know many residents that feel that they don't want to put a doctor out by going there and seeing them, and they feel guilty by asking for a face-to-face appointment, and they're missing out on the care that they need. So I just think those are good things that everyone has said. Really value all your input on that. This is a situation that we are looking into all the time, and improvements. We are in serious need of doctors, and we're all going to be trying to tap up Councillor Piccolo for his GP after this. And Councillor Salmons. Okay, thank you, Stephen. I think you can leave if you wish to.
I'll stay a bit longer because the next couple of items are of interest. Thank you.
Thank you, Stephen. Item 8, Integrated Medical Centre update. Can I ask Tiffany Hemmings via MS Teams to present this item, please?
Hello. Let me just share my screen if I can. Can you see that?
Yeah.
Excellent. Okay, so the Integrated Medical and Wellbeing Centres programme has been undergoing a little bit of a review since I arrived in April. And the review that I undertook identified that we need to bring the 4 projects of the 4 separate sites into a formal programme configuration and to put some resource into it as well. And to formally bring the project of Orsett Hospital closure into it. There's an awful lot of work going on around the closure of Orsett Hospital and how services will move, but it wasn't as formally linked into the programme as I thought would be beneficial. I've also moved to change the focus of the programme away from being entirely building centric to being how can we integrate services now, so we can really start looking at how we do that and start developing those integrated services alongside the delivery of fit for purpose estate. Now, the additional resource that the ICB has agreed to fund on behalf of Thurrock is, as you can see here, so John McIntosh is the new programme director. He's part-time, he's doing about 3 days a week at the moment, and he's been here for about 3 weeks. He's settling in really well. It feels like he's been here for a lot longer. I'm sure Katie will agree with me there, and he's doing a great job. And he's supported by a programme management office, which will ultimately have 3 people in it. So we've got Dave Marshall, who's leading that. We're looking for a programme management office coordinator that's not yet been appointed, and James Murray will be our programme support and will start in mid-November. Now, I think you'll agree that's a great step forward with running this as a formal programme with the 5 projects, which is the 4 sites and the closure of Orsett Hospital. In terms of Corringham IMWC, well, it was officially open today. I had a fantastic afternoon at Corringham. I'm sure Councillor Arnold will agree that it was very well attended and people were celebrating this fantastic opening event. It has been open for the previous couple of months, working out how services work together and how we're going to make things more effective in the future. We've also been running a lessons identified process, which started this week, so that we make the most of learning from what we've done well and what we haven't done so well in the programme so far, particularly around Corringham, but also from the other sites, so we can take that forward and make sure that we're a bit smarter in the future. The aim at the moment for Corringham IMWC as a project is to close it down as a project, because essentially it has effectively delivered, but to make sure that benefits realisation continues, so that we ensure that the benefits that we believe should be delivered are actually delivered. And as I said, this site really is now focusing on integrating services effectively, but also not just here, but across Thurrock. For the Purfleet IMWC, we submitted the outline business case to NHSEI, as it was then called, in March, and we received returned questions in May and June, and we've received very recently some further questions in October, which were around revenue affordability and capital affordability. That's something called CDAL for NHSE, for ourselves to NHSE, and we're in the process of answering those questions. So this particular project, there is a risk to it due to the commercial market rent, which is what the district valuer will value the site at, being below that needed for commercial viability from the builder. So discussions are ongoing to find a solution to how we move that to make it work. This particular site will have, for health services, it will have community, acute and outpatient services planned alongside primary care. and that will be provided by a resident GP practice alongside expected PCN appointments. As soon as the OBC is approved, we'll move on to FBC, and the current schedule for opening is 24-25. The Tilbury, we submitted that business case to NHSC in July, and again, affordability is potentially a constraint, so that CDL and resource finance will be required, and that question is again with NHSC. It's very similar to Purfleet in terms of the services that will be provided, although it will have different outpatient services to those provided at Purfleet, as well as local authority services, with of course the library going in here, and potential for community and voluntary sector services to be offered as well. There's a plan for a resident GP practice alongside PCN appointments, and as soon as the OBC is approved, we'll be able to move on with the FBC, and again, schedule for opening 24-25 currently. In terms of the Grays site, the fabulous news that you'll hear from Katie shortly is that the Community Diagnostic Centre will be based at the Grays site, and that we have got financial approval to commence this project, which is amazing news. Essentially the first phase of the IMWC, if you like. In terms of the actual full IMWC build, we have a very large funding gap because Dorset Hospital has come back with a lower valuation than we had originally expected. So there's a rather large cost and therefore a rather large gap. So we're working that through our governance at the moment, and Katie gets to present to the System Finance Leaders Group. She's been once to present where we're at and is due to go again later this year to see if we can work out how we might fund this building. We held a panel to determine between 4 different options for location of primary care services. They're the same services, just different locations around Grays IMWC, with 3 options being to remain at Stifford Clays, but effectively do nothing, minimum improvement or massive improvement to the site, or move it wholly to the Grays site. So while we managed to exclude the 2 options of do nothing or don't do very much, we had equivocal results between do a really big investment at the Stifford Clay site or open a new site on the Grays site. So we're going to have to rerun that panel again. We felt that we didn't have appropriate, easy to answer questions with that panel. So we'll be making sure we have lots more questions, but they'll be very simple. Last time we had compound questions, which made it quite difficult to score on the different elements that make up why a service should be at one place compared to another. So that outline business case is due to be submitted, and again, it will have community acute and outpatient services alongside primary care. The outpatient services is the bulk of the services from Dorset Hospital is expected to move to this site. And again, that schedule is currently 24-25 alongside the closure of Dorset Hospital. So that's all I've got for now. If you would have any questions, I'll be happy to answer them.
Thank you for that. Yes, the Coronel YMC today opened up. Absolutely fantastic facility. So nice to be in there and seeing it actually working and how well it works and how friendly everyone was. It's a very pleasant atmosphere. When we look at the other ones, straightforward question or observation, you can't afford this, can you? You can't afford it. Everyone's seen here, restraints, 6 million. Going back, you can't afford this project.
That's a question that we've put to NHSE, and they're coming back to us around whether we can have enough money or CDL particularly given to us so that we can afford to pay for it. I would agree with you at the moment that it's not looking great in terms of having enough money to pay for all of these sites, particularly the funding gap for Grays. But as I said, we are working through that because we have to find a solution to close Dorset Hospital. That will require our governance to come together through the System Finance Leaders Group to work out how they might fund this and where the funding might come from and how they might prioritise it over other items that are also needed by the system. So, for example, whether we have replacement endoscopes or whether we buy something else or whether this gets moved up the schedule, so to speak, for the Grays site. We have a certain amount of money set aside every year for building of primary care. It's quite a small amount of money over the entire system. And again, that's a matter of prioritisation of what needs to come. So yes, the money is the biggest risk, I think, at the present time.
Okay, thank you. I've had reassurances in these meetings from Anthony McKeever and everyone else over the last 3 years that these constraints, they're all dealt with, all planned with, we all know what we're doing. The Tilbury IMC was redesigned so many times. Now we're looking at the Purfleet, again, constraints. The Grays IMC constraints, £6 million valuation difference on the All Hospital. I'm struggling. I'm struggling with this. Though we get told in these meetings that it's all full steam ahead. Already, I will say that in a few meetings ago, I said, jokingly, oh, we'll be moving the closure of All Hospital to 2025. I was told that would never happen. It was 2024. Now it's in black and white in front of me, 2025. We can go 27, 28, 29, 30. Is there going to be a point when the NHS say, you know what, we're going to keep All Hospital open? Because it's never going to happen. I'm seriously concerned about this whole project, this whole programme of the IMCs. Being at Corringham today was a fantastic opportunity to see how this programme works. It was made very clear that the rest of the country is looking how Thurrock rolls this programme out with the IMC because they want to copy it. They want to use this as a flagship, the way that we work. We've got one opportunity to get this right. And these are our residents' health that we're playing with. NHS made a decision to close Ulster Hospital. We've come up with this programme, which is a fantastic programme of these sites. The Corringham facility is fantastic. Are we ever going to get the rest of these? We're going to go cap in hand to everybody to try and get this over the line. I just can't see, where we're heading. I can't see the answer to this.
Thank you, Chair. Thank you, Tiffany, for the report. I'd like to echo the Chair's comments in just being utterly unconvinced by the plan at the moment. We've got one centre open, which is lovely, but it does happen to be the centre that it happens to be located in the area of Thurrock that was least in need of extra primary care. It happens to be in one of the places, if you look at the report that Joe's going to present later, Director of Public Health is going to present later, the area that actually suffers from fewer health inequalities than places like Purfleet, which will be covering Averley and South Ockington, and Tilbury. Grays is obviously the largest town in the borough. Corringham is also the closest located to Basildon, to our existing actual big hospital. It's really, really disappointing that although we have this wonderful centre at Corringham, there now seems to be a big question mark over whether the communities that possibly really, really need this are going to get an equal level of service, because the figures don't add up. As the Chair said, there are too many funding gaps here. And is it in the end going to be, well, do you know what? Sorry, Tilbury, sorry, Grays, sorry, Purfleet, Averley, Ockington. You're just going to have to make do with something that isn't quite up to muster, because actually we didn't think this through, we haven't planned it correctly, and there are just too big a funding gap. Or can we have a guarantee that there will be a parity of service between what we're seeing at Corringham and the other three sites?
So In answer to your question, the reason Corringham happened first is because it was already in progress with NELFT prior to this programme coming to the table in 2015. It's been going on a very long time, so that's why this site came first. In terms of your comment around increasing primary care, it doesn't actually increase the primary care service in any of the sites. It provides a better environment for the current primary care to move into. So it doesn't automatically improve or increase the number of clinicians. That's a case for primary care to decide if they think they need to employ more clinicians and non-clinicians as part of that service according to the population that they're serving. In terms of what's coming, as I said at the beginning of this, I'm moving the focus away from just delivering buildings, which is where it has been, and more to making sure that we have integrated care services across the whole of Thurrock, because I firmly believe that we should have been doing that from 2015 onwards. That will ensure that we enhance the service delivered to every patient in Thurrock, regardless of there being a building in place. It will mean a better service, much more integrated, and starting with the patient rather than starting with a pathway, which is the way the NHS traditionally looks at things. So that's the way it's going, regardless of when we get buildings.
Okay, thank you, Tiffany, for that. So this idea, I'm slightly confused. So the point about the IMCs and the point that was made about them was that they would be the place where we put the care that is currently happening at Orsett, but that it would be local, that it would be closer to where people live, etc., etc. What you seem to be suggesting is that we are potentially going to drift away from that, and my concern is that that sort of drift, plus the fact that we've got these funding gaps for these other 3 IMCs, are we all just going to have to end up travelling to Corringham for care?
So I can say you won't all have to end up travelling to Corringham for care. The vast majority of services at 3 of the 4 sites are not the services currently at Orsett Hospital. The vast majority of the services at Orsett Hospital are currently planned to relocate to the Grays site. There are small amounts of service put locally at each of the other 3 sites, alongside quite significant amounts of community service and some primary care as well. So the location for the Orsett services is predominantly the Grays site.
Where we've got a massive funding gap, and we don't even know if we can repurpose the buildings on the site to fit it all in.
Thank you for saying that. We was all thinking it when we was all looking at each other. It's Councillor Piccolo, Councillor Polly, then Councillor Fish.
Yeah, no, I think everything that I was going to say has actually been said by the previous speakers. I mean, I think it's atrocious. We were sold the fact that we were going to get 4 local medical centres when Orsett closed down. It now appears that we're only going to get 1, and the others will be disjointed, or the other 3 will turn into 1. It's just, to my mind, it's appalling. We were sold a red herring many years ago just to get this off the ground, and I'm not at all happy with the way things seem to be going. I think the people of Thurrock are being sold down the road, but that's just my comments, Councillor.
Councillor Polly.
Thank you very much, Chair. This seems to be a movable feast. The rationale, the genesis behind closing Orsett Hospital was it's not fit for purpose. We are now looking at extending. So are we saying that we're putting our residents and our healthcare staff in a building that is possibly harmful to them? Or are we saying that perhaps the initial assessment of it not being fit for purpose was not correct. So I have a concern about that. If it wasn't fit for purpose, how can we just keep extending the life of it? I also have a concern that the only thing that is constant and the only thing that everybody is adamant when they address this committee is the closure of Allsett Hospital. We have repeatedly, cross-party, supported that that is the wrong way to be looking at this. When you've delivered the other services, then you close the hospital. It is totally horse before the cart, or the cart before the horse, in my view. The other thing is that we are a growth agenda. We've heard on every report in this meeting about the under-provision we already have. We're not increasing capacity with these IMCs. We are only treading water with them. We've had a briefing this evening on the local development plan. The housing numbers that are coming to this borough are huge, and we can't deliver the healthcare now for our population. So that also gives me a concern. To suggest that with developers watching Allsett like a hawk at the moment, to suggest that the land value of the Allsett Hospital site in prime development land is £6 million, I think, I don't know where that figure has come from. I really don't. But as Councillor Parker said, we're talking about a shortfall of funding for just one of... We're saying that that will fund the Grays IMC when the Tilbury one, the Purfleet one, and dare I say it, there was talk of a Knockenden one, in a fifth one. We're focusing on the four, but there was suggestion of a fifth one. That seems to have fallen off of the radar now. That doesn't seem to be in any type of discussion. I agree with your comments that it's not affordable, it's not a deliverable. Perhaps we need to go back to the drawing board on some of this. I do have a specific question about one of the services on Purfleet IMC, and I think it was one of the other ones. Sorry, I do apologise. It says acute services. Can we please define what we mean by acute services? Thank you.
So acute services are generally those delivered by MSCFT. So they would be outpatient appointments.
Sorry, that doesn't answer my question. Acute is ED.
Acute services are provided by Mid South Essex NHS Foundation Trust. That's the way the NHS describes the services. We call them an acute trust as opposed to a mental health trust or a community trust. So their services at Allsett Hospital are outpatient appointments.
So we would be looking at the eye clinics and those type of...
It's a whole series of things, actually. So it would be respiratory clinics, it might be gastrointestinal clinics, it might be musculoskeletal clinics. It's everything that's currently being delivered to the population of Thurrock from Allsett Hospital in terms of outpatient appointments.
Councillor Fish.
Well, I had a question which was going to be frivolous, really, because of exasperation at the situation that we find ourselves. But from what you've just said about the Grays site incorporating most of what's at Allsett, and the funding gap for Grays appears to be enormous, and I'd say possibly it's insurmountable, is part of the plan now to keep Allsett Hospital open?
That is not currently the plan at all, no. The backlog maintenance for Allsett Hospital is more than rebuilding, potentially more than rebuilding might cost somewhere else. So no, I don't think that's on the table.
Councillor Salmons.
So are you suggesting that if we don't get the IMCs, Allset will still close regardless?
So the plan is that we cannot close Allset until we have safely relocated the services to appropriate locations in Thurrock, which has always been the case.
Which will be where?
So the current plan is for the IMWCs. If that does prove to be completely unaffordable as we go through the process with NHS England, if they come back and tell us that we can't do it, then we'll have to come back to you and find an alternative way of delivering those services. But at the moment, we're still waiting for NHS England to come back to us with an answer, essentially. We've gone to them with our outline business case. They then will need to come back to us, and we haven't got to the end of that process yet for either Purfleet or Tilbury.
So in the meantime, the residents will suffer a long time, won't they?
Yeah, indeed.
Services continue to be delivered to the same standard as is required by the NHS in Thurrock for Thurrock residents.
Yes, but that's because Allset is still open. The question is, what if it shuts because these aren't going to open?
So there is no plan to close Thurrock before we can safely relocate the services to elsewhere in Thurrock.
Okay, thank you for that, committee. Some questions, serious questions need to be asked. One, evaluation of the hospital, £6 million gap. If it's the land, then it's probably the only bit of land in Allset that's devalued, which I'm scratching my head at. I don't get that.
I believe the valuation is related to some particular circumstances of the hospital on the site, which reduces its overall value because of the issues with removing the current building, which would be extremely expensive.
Well, there's always one way. Don't remove it. Just keep it there, because it sounds to me, and I'm not being facetious here, you've got a serious problem. You're telling us that you're going to close Allset Hospital, whatever, and if we don't build the IMCs, which looks like they may not happen, you're going to still relocate these services, so we better start prepping the scoutles to deal with these IMCs then. Is that where we're going to locate them? I don't see the answer. You've really got to meet up with maybe our MPs and everybody. You've got to get in the same room, back this out, and come up with a solution. You're playing with our medical care in Thurrock. This has meant to be a shining light, and all I'm seeing is problems after problems. We've been told stuff that is not true. You know, when we're told here all the red tape's going to be removed and everything, it's not happening, is it? It's just a roadblock after no roadblock. We need some serious answers, and some serious people need to get involved and come up with a solution to this, because otherwise we will be a laughing stock again. I'm going to move on from the item from here.
Sorry, Tiffany, this does seem like you've had a bit of a hard meeting, so sorry if we've, but obviously we're passionate about our community. We're here to challenge. That is the job of Overview Scrutiny. Is there something we can do as a committee that can help you deliver these? Do we need to be lobbying? Do we need to be making representation?
So I'm in the process of setting up a meeting with Councillor Arnold about exactly what could be done to potentially move this forward. So I will go ahead and make that arrangement, and then potentially we'll come back to you if there's anything further that this committee can do. Yes, thank you very much for your help. And don't worry, I have a very thick skin. I've managed to get quite a lot of resource from the ICB to support this programme, so I want to deliver the best I can against what the resource is available for the people of Thurrock.
Thank you, Tiffany. So at the end, what we're looking at is who is holding this up and who is causing the delay. I think after tonight we can see that this isn't coming from the council side. This is a financial gap coming from the other side, which I don't see the way through. So again, apologies that this was a tough meeting. Councillor Polly's correct, we're very passionate about this subject. Many of us have been on it, well, I've been on it for 4 years, and some of the other members have been on it a lot longer than that. And some of the other members have been 2015 that have been involved in this project. So there's a lot of invested time. Okay, thank you, Tiffany.
Thank you.
Item 9 has been deferred to a later meeting. So Katie, do you want to come in and do your briefing on the the community diagnostic centres?
Sure, yes, thank you. I have some slides to share, so I will just bring those up on there. Thank you. So community diagnostic centres and a focus on exactly what this means for Thurrock. So just to provide you with some background to this, the Community Diagnostic Centre programme is a nationally funded programme, and it is in place specifically to increase diagnostic capacity. The programme started within 2021, so this is a new programme across the past 18 months. The new centres in place is going to allow us to deliver tests and scans for people locally, so it will make services far more accessible for patients and far more convenient. Our team undertook an engagement survey that was completed across summer, for which we had just over 750 people respond, and questions were specifically focused on those things that are important to residents in terms of location and also facilities across centres, and all of this feedback has been used in order for us to develop plans for centres across Mid and South Essex. I'm really pleased to say the fact we got confirmation last week about having national funding now in place to build our first community diagnostic centre, and that will be in Thurrock. Our ambition is to also have centres across Mid Essex, in Braintree, Basildon, and also Southend too. So some of the key messages for you in terms of community diagnostic centres. The real aim of these centres will be in order for us to provide faster tests for patients, and in turn that will allow us to have an earlier in turn, faster tests allow us to have an earlier diagnosis, and hence the ultimate aim of this is to improve health outcomes for patients. The key premise for community diagnostic centres is separating out planned care. Quite often at the moment, our diagnostic services on acute sites are inundated, and quite often planned patients are cancelled because emergency patients bump. And so the aim of these community diagnostic centres is to have specific separation between elective activity. So it's going to help us work through significant backlogs we've got at the moment for testing. Some of the key messages for our communities are the CDCs in place are there to offer a range of specific tests, and it will be closer. So at the moment, residents for Thurrock travel across and have tests and have tests outside of Thurrock. It will allow more people to have their diagnostic tests locally. These for new centres, it is additional capacity. This is additional staffing, additional capacity, additional machines. So in turn, this additional capacity is going to help us to have faster testing. So it will reduce the current waiting times. The pathway development work for this enables us to work alongside GPs so that they will have better access into centres, so that patients can have tests closer to home, and those results will go straight back. At the moment, as I mentioned before, a patient can come for a diagnostic test at an acute hospital, and it can quite often be delayed because emergency patients are, because the demand for emergency patients is going up. This will provide far more assurance around being able to get appointments for planned patients. So the Thurrock CDC, the centre will be based. So the Thurrock CDC will be based at the Thurrock Community Hospital site, and therefore it becomes part of our aim of having a Grays IMWC centre there. So the CDC will be based at Thurrock Community Hospital site. There is already services on that site, so there are community outpatient clinics on that site, and there is the MSK triage service on site. So it's going to help us with integration of care between those existing services on site and the extra diagnostic facilities. It will enhance the diagnostic facilities available for Thurrock, and it will specifically bring MRI into Thurrock, and it will bring CT into Thurrock. We do have X-ray and ultrasound at Orsett at the moment, for which the intention is these services will move from Orsett into the new community diagnostic centre facility. However, one X-ray machine will stay at Orsett Hospital until we build a new urgent treatment centre at the Grays site, because the minor injuries unit at Orsett at the moment depends on access to that X-ray machine. So that X-ray machine stays there until the urgent treatment centre moves across to Grays. This reaffirms our agreement to re-provide diagnostic services from Orsett Hospital in Thurrock, and actually from having something new in place and a new national programme, it allows us to significantly increase diagnostic capacity for Thurrock. So it isn't just like for like from Orsett, it is increasing diagnostic services. Staffing is our key challenge with this one, and it is a countrywide challenge. We will be recruiting additional staff for the centre, and so because this is a challenge, it is something that we're already looking at now in order to form staffing plans. We've had recent success across our acute hospitals, and this is specifically with international recruitment. I think across our hospitals at the moment, we have 27 new radiographers that have been identified from a region-wide international recruitment campaign. So international recruitment will form part of our staffing plan, alongside having a look at training programmes for new roles. We know that some services are more harder to recruit to than others. So there is a particular national shortage for sonographers who operate ultrasound scanning. If we find ourselves struggling to fill roles, we do already have local community providers for ultrasound. So we do have the opportunity of discussing extra capacity through those existing local community providers to provide that within a community diagnostic centre at Thurrock Community Hospital. Parts of MSC system as well also have support from the Anchor programme. So our aim is also to offer recruitment opportunities locally. So the services that will be on offer in the Community Diagnostic Centre are X-ray, CT, MRI, ultrasound, blood tests and heart and lung tests. We already have X-ray, ultrasound, blood tests and heart lung tests in Thurrock. However, this is about increasing capacity and also increasing range of specific tests offered. This is the first time of having permanent CT and MRI capacity for Thurrock. At the moment, as I mentioned before, patients have to travel to Basildon Hospital for CT, MRI. Once the centre's open, that will be local. So just to finish off then, timeline for this. So the national funding agreed now, that came through last Friday. We'll be going through a period at which we will be submitting a planning application through Thurrock Council, and that will start from November. We expect, all going well alongside the planning application, for works to start in spring 2023, and our aim is to have the centre open for patients from early 2024. So I'll take my slides down in case there's any questions.
Thank you, Katie. I apologise for skipping over your report on there, but you are a shining light of hope after what has just passed. Thank you for that. This is fantastic news. The agreement, as you say, has gone through. I think anything like this is just such a fantastic opportunity for Thurrock to have. I like the way you did cleverly skip over the words IMC at Gray's Medical Centre to start off with, so that was well done there. Yeah, I don't really have any real questions about it. I just think it's a great opportunity. It's definitely going to help the backlog that we have. You know, this is why the whole idea of this funding was to help clear our backlog of diagnostics. And so this is going to be fantastic if they can get an appointment with their GP to start with. I will add that. Councillor Polly first.
Thank you, Chair, and I'll keep it short this time. 2 questions and 1 statement. The CDC, what hours are we looking at it being available? Because I know the unit that was at Southend, the scanner there, did great work, and I see Karen, one of the nursing charges at the ED department, on your slide. So I know it did help, but we often have elderly patients in care homes that are on blood thinners, they've had an unwitnessed fall, protocol policies require that they have a CT scan. This is one of the best reports that I've seen in a long time, because it is actually starting to revisit stopping people getting to the front doors of the ED department. It's actually about trying to treat them in the community. So I think that's great. But it would be, could an ambulance take a care home patient to the CDC to have their scan rather than taking them up to the hospital? And what hours would we envisage the CDC opening? Thank you.
Yes, thank you. So the MRI, CT, X-ray and ultrasound, our aim is to build up so that we have a 7-day service, and that would be running 12 hours a day from 8 a.m. in the morning through to 8 p.m. at night. We will likely build up to that, but the intention is to have those services 7 days. The other tests, so for lung, heart tests and also blood tests, they might be slightly shorter. It's unlikely they'll be 7 days a week, but we are looking at extended hours. From our citizen engagement questionnaire, there was a high interest for appointments early on in the day or later on at night. That came through really strongly for us. So the aim of these centres and the steer nationally is to be open 7 days a week and offer appointments earlier in the day and later at night. In terms of your question about the patients in the ambulance coming to the centre for their diagnostic, as mentioned previously, these centres are focused on planned activity. So this is elective patients. And the purpose of it being elective is because the planned patients are currently suffering because of the emergency workload at the acute sites. And so the focus on these centres is planned work. This will, however, release capacity at acute sites. So the demand on those acute diagnostic services will allow for better access for the emergency flow also. Hope that answers your question.
Councillor Pothecary.
Thank you, Chair, and thank you, Katie, for your presentation. I mean, the CDC sounds like an amazing step forward in terms of making sure that we've got that extra capacity for diagnostics. I do have a couple of questions about detail, though. You mentioned that it is supposed to form part of the Grays IMC. We've already heard tonight that the Grays IMC has potential issues around cost, around configuration. There's lots of questions, unanswered questions about Grays IMC. It is the least developed of the whole IMC plan. And there seem to be some questions around what we do, how that site would be configured. How tied, so the first question is, how tied is the CDC to the Grays IMC? And is it that the CDC will happen no matter what happens with Grays IMC, or are those two tied together? And then connected to the further sort of extension question from that would be, how future-proof is the planning for the CDC, given that, you know, in a couple of months' time, we could be told to rip up the plans for the Grays IMC entirely and go back to the drawing board? The second question I have is around the timeline. But by my reckoning, according to this timeline, you're hoping to clear planning and do all the things like awarding of contracts, etc., within about 6 months. That's quite tight. I'm just wondering how many assurances we have that we'll get spades in the ground by the end of spring 2023. I'd love them to be there, but I think as a committee we're used to being told dates that continually then keep shifting.
Yeah, thank you. So the first question about what if plans change for the Greys IMWC. Nationally, CDCs can be standalone. The benefits of having the CDC at the Thurrock Community Hospital is there is already hospital services there. So there are already community clinics there, and there is already MSK triage assessment. They are frequent requesters for diagnostic tests. And so even if worst case, nothing happened for Orset, and I'm not suggesting for one moment that that's going to happen, it would still be a viable solution to put the community diagnostic centre at Thurrock Community Hospital site. So the intention is we will absolutely be putting the CDC there. On your second question about timeline, it is a really, really tight timeline. The national CDC team wanted to ensure every system has their first CDC early on. So we are being pushed for tight timelines. We have put a pre-application in for planning already and are expecting an initial meeting shortly for that. We have our architect on board. We have all of the planning information sorted and ready. We'll be going at risk, I guess, in terms of doing detailed design and appointment of contractor alongside planning and iterations. It may be needed if anything comes out of planning, but we're going to have to run activities concurrently. But we are committed to getting that first spade in the ground in spring 2023. It's important to us because we need the additional diagnostic capacity. So working at pace on this is really important to us. So team are mobilised, are ready. It's going to be fast paced, but yeah, the commitment's there to start the construction work from spring, and I can keep you updated as it is we progress.
That'd be lovely. Thank you, Katie.
I'd like to just say we're going to have to extend the orders today. I'd move the motion without, I'd like to move a motion without notice to suspend the council procedure to rule the 11.1 to allow the meeting to continue beyond the 2.5 hour time limit. So, thank you. Thank you, Katie, for that real positive report. Thank you. And we look forward to it. And I'm sure that the timescales will be kept to. So I'm more positive feeling about this one. Thank you. You're welcome to leave, or you can stay if you wish. It's up to you. Thank you. Bye. Okay, item 9. This item is deferred to a later meeting. Item 10, request to consult for the charging of assistive technology monitoring services. Can I ask Ian Kennard via MS Teams to present this item, please?
Thank you, Chair. I appreciate everyone's time this evening, and hopefully everyone's had an opportunity to read through the paper and the proposal. The ask is basically for adult social care to actually consult with individuals that are currently accessing the monitoring service that's performed out of Harty Close. There are in the region of 2,200 individuals that have over 4,500 pieces of equipment that currently connect into that service, which runs 24 hours a day, 7 days a week, and provides emergency call response services, as well as family alert services to individuals accessing there. The reasoning behind this is that we face significant financial challenges in 23-24 financial year, And this is a potential revenue stream that we can explore, as it'd be very difficult to find other ways of generating income and or providing savings on existing contracts, as we're in the lowest quintile of spend in the country for adult social care services. So this is a potential stream. It's non-statutory, and as outlined in the paper, there is quite a mixed approach across the country to charging for these services. So I'd like to leave it there because I know we're pressed for time, and open up for any questions at all that people may have on this.
Thank you, Ian. We went over a lot of this on our pre-brief regarding this. As you know, my concerns were the affordability of this. So the means testing for me was the key item. I know this is only a request to go out to consultation. So some of obviously the questions is how that consultation is going to be done. Are we going to be asking the CVS or Health Watch to go out and do this? I know they've done a fantastic job on your last consultation, literally going up and talking to people, door knocking them and getting the information off them. I think that sort of level of consultation would need to be done again, not just sticking out there and getting sort of like 40 replies back. So this is it. I know there's a bit of a scope between that, looking at the different areas that are charging and how much they're charging. And we're looking at anything from maybe £1 to a flat fee of £5 a week. Before I continue, does any other members have any other questions? Councillor Fish.
Yeah, I have a question on the level of charging. Obviously, the intention is to means test people, but are we saying that everybody would be paying something, but there would be a limit to what anybody pays?
Well, currently we're not set on a particular fashion. If we were to means test, obviously we'd have to consult first of all, come back with ourselves to see and evaluate the feedback to see if that's worth pursuing. But if we were to get to the position to actually means test for contribution, it would be applied in the same fashion we currently apply all other non-residential means tests. So you pay what you can afford to pay. If you're assessed at paying no contribution at all, you would pay nothing. So it's effectively the same principle we would apply to home care or direct payments or day opportunities.
Any other questions? No? Okay. Councillor Glow.
Yeah, just one thing. Are the means tests going to be carried out annually? Because obviously people's circumstances can change during the course of a year. And also, do we know what there's 2,000 odd, I think you said there were people using it. Do we know the cost of mean testing those people, staff costs, and deduct that from the savings we're making on what it's costing at the moment? I mean, if it's going to end up as, I don't know, £10,000 or £12,000, it could be putting residents through a lot of problems just to save a small amount of money. So I don't know whether you've got any answers to that.
I do have some, yes. In relation to any means testing, we have an obligation to review means tests each year. Our initial means test is generally done face-to-face, because obviously we'd like to look at the best way of approaching a means test, depending on each person's circumstances. For example, if they're living as a couple, we would, should the person consent to do so, we would assess individually or as a couple to see the best financial outcome for the individual, propose both outcomes, and then everyone gets to choose which they would like. Most people will opt for obviously which is of the greater financial benefit. So we would review that, and the following year we would normally undertake a light touch review, because we are able to, with the individual's consent, access DWP information to obtain the vast majority of the information we need to actually undertake that assessment. So that does feed into the second point to a degree. So it tends to be more time intensive, the first assessment that's done, then it gets progressively easier to do subsequent years. So a financial assessment officer would normally be able to undertake 8 face-to-face assessments each day. But if they're doing a desk-based assessment, they could carry out 40 to 50 a day. So it becomes a lot more viable the longer you progress that assessment process for. Of the 2,200 individuals, quite a vast majority of people are currently known to adult social care. I don't have the exact figures to hand. We did a 20% sample when looking at this before the paper came to HOSC. Of that 20% sample, I think from memory, it was in the region of about 60 to 70% were currently known to adult social care in a variety of different capacities. Some had been assessed, then refused services and chosen just to keep assistive technology. Other people have existing care packages, so they're already known to us and probably had financial assessments in place should they have chosen to have them. So your point's well made in the fact that the exact outcome and the exact resource intensity that it would take to actually get all the assessments done is not quantified at the moment. But obviously we don't know what the initial feelings or initial responses would be to the idea of charging. So I wouldn't necessarily want to press ahead doing that work initially, because the threat of people withdrawing from service might be a deterrent in itself not to charge. So it's very difficult without engaging with individuals and seeing what the type of motion is and the type of response that we would get from that consultation before we'd undertake that piece of work. But it is something we would do and obviously bring to HOSC as a part of the overall recommendation after a consultation.
Thank you, Ian. Any more questions? Nope. Okay, cool. The Health, Wellbeing and Overview Scrutiny Committee is asked to comment and to support the recommendation for the consultation with individuals using the A&T potentially charging a fixed fee for accessing the monitoring service. Do we all support that going forward? Agreed? Great. Thanks, that's agreed.
Thank you very much, Chair.
Okay, thank you. Is Ian free to go? Has he got? Yeah, you're free to go. Thank you, Ian. I'm aware that we are coming to 2.5 hour meetings. Does anyone need to have a comfort break for 5 minutes before we continue? No? Okay, brilliant. Thank you. So item 11, annual health public reports. Can I ask Jo Broadbent to present this item, please?
Thank you, Chair. I'm going to share my screen. I've got some summary slides to show you. So it's a statutory requirement that Directors of Public Health produce an annual public health report each year on an aspect of health and wellbeing within their local area. This report is actually a follow-up to an annual public health report done by my predecessor, Ian Wake, back in 2016. That report focused on long-term conditions care within Thurrock and made a range of recommendations aimed at improving long-term conditions care. What we wanted to do with this report was actually see if we could look at what the impact had been and see if there were further recommendations we should make to improve that care. And we've done that through the lens of cardiovascular disease in particular. This might seem like quite a specific topic to choose, but actually it's a really important clinical consideration for us in Thurrock. Cardiovascular disease is the main clinical cause of premature mortality in the UK. 1 in 4 premature deaths, so that's death before the age of 75, is caused by cardiovascular disease. It's also the main clinical driver of health inequalities, and we know that premature mortality from cardiovascular disease is higher in groups that experience inequalities, those living in more deprived circumstances and people living with severe mental illness and learning disability, for example. So focusing on cardiovascular disease provides the greatest potential for us to reduce health inequalities and reduce that premature mortality. Just to illustrate the impact within Thurrock, these couple of graphs here, at the top is a graph showing life expectancy at birth in all the districts and boroughs in Mid and South Essex. And if you look to the right-hand side, you'll see that Thurrock has the lowest life expectancy within Mid and South Essex. And for both men and women, life expectancy is below the England average. If we consider just cardiovascular mortality and that premature mortality, so death before 75 years, that's the graph at the bottom, and we can see that Thurrock has a rate that is higher than the England average and higher than most of the other districts and boroughs within Mid and South Essex. So there's clearly a lot of potential for our community to benefit from improved cardiovascular disease prevention and treatment. Just a couple of other facts about cardiovascular disease in Thurrock. When we look at mortality attributable to socio-economic inequality, so related to deprivation specifically, cardiovascular disease is the greatest contributor in Thurrock, accounting for 35% of excess deaths. And quite shockingly, when we looked at data on people living with severe mental illness, Thurrock has the second highest premature CVD mortality rate in England among that specific group. So we've done a lot of work, as I said, since 2016, but there's still further to go. Despite those striking facts that I've just shared with you, there have been notable improvements in cardiovascular disease care since 2016. We've talked a lot about integrated medical and wellbeing centres today, so I won't dwell on the first point on my slide here, but the report in 2016 did contribute very much to the thinking around integrating care in single sites. When we look at the quality of care for cardiovascular disease in primary care, which is where a lot of this activity happens, we've seen some notable improvements in care. And that's despite the small issue of the COVID pandemic in the intervening period. We know that that's put immense pressure on primary care during the pandemic and subsequently with increased demand. But despite that, our primary care colleagues have really made some notable improvements. So I've just summarised some of these here. Annual diagnoses of hypertension have increased across Thurrock, and the diagnosis gap in Thurrock is the smallest for all of those districts and boroughs in Mid and South Essex. So that means the number of, the proportion, should I say, of people with hypertension who don't have a diagnosis is the smallest in Thurrock. Also, the quality of care for hypertension in all of our Thurrock PCNs compares really well to national targets. I think the greatest improvement we've seen, though, is in the management of atrial fibrillation, which was below average for England back in 2016 and now exceeds the national targets. So that's been a real improvement. We still see quite a big gap for diagnosis of coronary heart disease and high cholesterol, but actually, again, we see that quality of care for people who do have a diagnosis is very good in Thurrock. So the impact of a lot of the initiatives that we've seen since 2016 has been, on the whole, positive. We do feel, though, that there is further that we can go to continue to address the inequalities and premature mortality driven by cardiovascular disease. And the report makes a number of recommendations that build on the work that's already in place. So I won't go through all of these in detail, but they essentially fall into three categories. One is around workforce. We've again already discussed this evening the underdoctoring within Thurrock, and it's really great to hear the initiatives that Stephen has described that is addressing that, because that's a key factor, I think, in quality of care that we see. But it's not just about the primary care workforce, it's also about the wider workforce, our community and allied health professional workforce, and those R's roles as well that Stephen was talking about. Looking at the data, we also think that we could do more targeting to have the maximum population impact. We think that we need a real focus on targeted case finding. Given that quality of care is good, the greatest impact on population outcomes is going to be generated by increasing diagnoses and getting people into care. So targeting older people, those who are housebound, those with higher BMIs and certain ethnic minority groups is recommended. We're also going to target certain preventative programmes such as NHS health checks, and we need to do some work, I think, around follow-ups for SMI and learning disability health checks as well. And the final area is around the service model. These recommendations do fit very much with the integrated and holistic service model that we're envisaging for the integrated medical centres. It's very much in line with the recommendations in the Better Care Together Thurrock Health and Social Care Strategy that this committee has looked at. We've looked at the evidence base around things, for example, personalised care, health coaching, motivational interviewing, and building all those things into a holistic service model we feel will improve outcomes further. So in taking this forward, our next steps will be to establish what we're calling the Population Health and Inequality Steering Group. This is actually to take forward a lot of the Better Care Together Thurrock strategy elements that are related to population health and inequalities, and the recommendations within this report will actually sit really well alongside those. So we propose to pull the two sets of recommendations together into a single action plan and report on that. And that group will also link back into the ICS's Population Health Improvement Board as well. So I'll stop there and take any questions. Thank you, Chair.
Thank you, Jo. As I said before, brilliant report on this. Thank you so much for your work and effort that's taken on this. It's a really great piece of work. Even though disturbing reading, I will say, it is concerning. We are in that area. One of the things that's going through, I know we focus, so I will explain this come through into the Wellbeing Board as well. As this is the second time I've seen this. We have a question that comes to my mind. I remember coming to this board before regarding heart disease and chest infections and all that stuff. We moved to providing the vape shops to help quit smoking initiative. Is that initiative still going, or has it been rolled back at all?
It has been severely impacted by the COVID pandemic because, of course, shops they closed down during the COVID pandemic, and what we think has happened is people have moved online to order vape products. So we're now seeing much less traffic in terms of smoking cessation through those shops. We still have an arrangement with one of them, but I think because the way people access vaping has changed, I think our service model needs to change. So it is still part of the offer, but it's less of an offer than it was pre-COVID.
One of the other questions linked to that was that do we have any evidence from the retailers that the actual sale of tobacco itself is down within Thurrock to back up the figures that people are smoking less?
We do have figures on that, but I don't have it to hand.
Sorry for throwing you under that on that one.
Yeah, no, that's fine. So we did do a needs assessment on tobacco control last year, so it will be in there because enforcement is obviously a key element of tobacco control. So let me get back to you on that.
Okay, right. First up was Kim James.
Thank you, Chair. Jo, I just wanted to ask you, it says about the numbers have dropped since 2016 for the AF, identification and various other things. I remember way back, there was a whole piece of work done in Thurrock around, I'm not medical, so I'm going to just describe this in the best way I can, which was around the monitoring, where each GP surgery were given a very tiny little thing that you just held with your thumbs on, and it read whether you had AF, and it was picking it up really early. And it ran out across all of the surgeries, and they were all, it was all being done, all the patients, every time they went in there, no matter what you went in there for, if you were sort of in that category, they'd done it. And I know there's really good figures coming back to say how much they'd identified. So the numbers that you're giving that show the drop, do you think that's from then? Because now we don't get to see doctors, except for Councillor Piccolo. We don't actually get to see a doctor, so that can't be happening because they don't do that over the phone. So are these facts and figures and numbers recent or in that period of time? Because that could all be back from when we were having that programme was running.
So I would have to go back and look at the exact figures for atrial fibrillation, but what we looked at was 2016 up to the most recent data, and generally for all of the indicators that we looked at, we saw an upward trend year on year. I would have to go and double check that, because some of them did show a slight downturn during COVID, but the general trend is upwards. So clearly people who are at higher risk of atrial fibrillation are still getting identified and diagnosed.
Councillor Fish.
Thanks, Chair. Do we know why some minority ethnic groups have a higher prevalence of CVD?
So it's probably multifactorial, and there's not a single answer to that. There's likely to be a genetic component. There's also likely to be a health risk behaviour component. So we know, for example, that smoking rates are higher among certain ethnic groups than others. It's also potentially likely to be related to access to services, getting access to preventative support, early diagnosis, can impact on your outcomes, even if you have established disease. If it's diagnosed early and well managed, your outcomes will be better. So I suspect there's a number of multi-factors that play into this.
So on the access to services, what are the challenges there?
So to take an example, as you've said, so certain ethnic minority groups have higher rates of certain cardiovascular diseases. But when we look at the rates of diagnosed disease within Thurrock, there is a higher rate of underdiagnosis in all our non-white ethnic minority groups than the white ethnic minority group. So that's for cardiovascular disease. But actually, we've looked at a number of other services. So drug and alcohol support is another one where we see this underrepresentation in service. So I think there is something complex going on here about why across a number of services that we've looked at, we see this underrepresentation. I don't think we fully understand it, but I think we need to look into it and understand that better. Whether it's something about accessibility of services, whether it's something about how willing people feel to access certain services coming from different groups. I don't know. I think there's more questions to be asked there.
So maybe the way the service is delivered needs to...
Potentially, yes. I would say, yeah.
Thank you.
Yeah.
Thank you very much. I'm just wondering, and the timing probably isn't right on this because of the timelines of the report, but we mentioned COVID in here and effects, but initially COVID was a respiratory illness that then got moved into cardiovascular because of the PEs and like the pulmonary embolisms, clots. Do we need education that shortness of breath, people being short of breath, is a CVD concern? It's not just a COPD concern. And the second question was, I myself have a BMI that I'm ashamed of to be, and we mentioned the quit smoking, and I am a success story of one of Thurrock's quit smoking campaigns. Thank you very much. But also, there used to be like people like Vitality and that used to do education around food, education around exercise. You know, it isn't always about taking a pill. Very often, it's lifestyle choices, and I think, as we discussed earlier, in some of our more areas of deprivation within Thurrock, that is where our biggest piece of work needs to be done. Thank you.
Yeah, just on that. Well, firstly, congratulations on quitting, because it's really not easy, is it? So that's great. We do have a whole systems obesity strategy in Thurrock, but given everything that's happened in COVID and time moving on, we realised needed refreshing. So we're working on that at the moment. Because you're absolutely right, and the same approach to tobacco. We can't just have public health services that offer smoking cessation support or weight management. It needs to be a whole system approach, because these are really complex and intractable issues. So we're looking at that whole system obesity approach right now. We're going to have a stakeholder workshop in January to help us think through what we really need to do and how we can work with the whole system to reduce the obesogenic environment, working with children and young people, that best start in life approach. So the family hubs work that you may know about that we're doing in Thurrock at the moment, we've got funding for family hubs for young families, and we've got an infant feeding strand of that. So our, you know, our healthy weight work starts right at birth. So it is a whole systems approach, you're absolutely right, and there's work going on that, and this will come back to HOSC at some point next year when we've done a bit more work on that. So I look forward to discussing that with you and presenting it to you.
Thank you, Jo, for this, and thank you, committee, for your answer, for your questions. Just on a final note, you're right, it's a whole overview of our health. It does cover obesity, but it covers so many other, I guess, inputs. As I say, our strategy of our local shops, the amount of fast food outlets that we have. I just pick on Stanford because I know we've got 27 in Stanford and Coronham. We're looking at obesity and more healthy options what we could do as a council with our local plans and our local development. One thing I'd like you to take away was that I know we're looking at things like reduction of smoking is going down, but obviously we know in Thurrock, we're not blind to it, the use and extreme use of cannabis, and that is often either mixed with tobacco or is straight cannabis itself. So it's great that we know that maybe tobacco's going down and all that sort of side of it, but the prevalence of smoking of that, especially with people with mental health, so it all sort of bleeds in that. And coming out of a pandemic, a lot of people were stuck in their houses. So obviously we've got a knock-on from lack of exercises, and that can go with alcohol. It's a whole big combination of things. So if some sort of inclusion into that report of the use of recreational cannabis for inclusion on that sort of side of it. Thank you for your report, Jo. Thank you. First, I do want to say I really appreciate you. I know this is a very long, extra long meeting tonight, but I think it shows great commitment from the committee on how they're challenging and scrutinising everyone tonight. So it's been a real great effort. And then your patience for going through reports, we're getting there. So we are now on the, item 12, adult housing and health fees and charges, pricing strategy 2023-2024. Catherine Wilson via MS Teams to present the item, please.
Thank you very much, Chair. As you said, this report is regarding fees and charges across adult social care and also libraries. It lays out the rationale for the charges listed within Appendix 1, which members have. For adult social care, there are very few changes from last year's charges, but I will discuss those in a while, the ones that have changed. For libraries, there's been some very detailed work to ensure that charges are clear and consistent. And that detail is at Appendix 1, and it illustrates a considerable range of charges, and these are clearly available to residents who access our library. These charges include two specific new areas that are in response to resident requests to have items of stationery and refreshments available at each library for a small cost. You'll also note that there are charges...
Say, Catherine, we're struggling to hear. I don't know if you can get a bit closer to the microphone at all.
Sorry, I'm probably not speaking very loudly. Sorry, so they are, let me just go, yeah. You'll also note that charges are across borrowing and late returns of items, for requests for information from other libraries, charges for lost and damaged items, and also a scheme of charges for room hire, all supporting the generation of income for our libraries. For adult social care, there are two main areas of increase in fees, which in turn potentially could increase our charges. These two areas are domiciliary care and residential and nursing care. For domiciliary care, we're currently in the final stage of increasing charges, a process that was agreed through HOSC and Cabinet. This has been an incremental increase in 3 stages. This final stage of the increase to the maximum charge this year to £17.92. The other significant area in this is the cost of residential and nursing beds within our care homes. The fees paid to providers have been increased, as you will note, and this was to stabilise our very fragile care market, particularly post-COVID, and support our residential providers in the delivery of their care. As the committee will be aware, for adult social care, charging, all who receive services are offered a financial assessment, which we did have reference to in Ian's report about AT. This is a comprehensive process which is detailed on page 93 of your packs of information, and the assessments are carried out by our financial assessment officers to ensure fair and equitable charging takes place. Within the assessment, certain income and expenditure can be disregarded before the calculations are made regarding any charge. For example, expenditure relating to an individual's requirement for support that increases independence, e.g. equipment, and also the fuel allowances to support through winter and the current economic challenges would also be disregarded before a calculation of charge was made. The council tax increase that was made available to adult social care, the consequence of that was duly used to support services responding to increased demand, and also to contribute to maintaining the charging levels that you will note at Appendix 1. 80% of adult social care services are bought externally, and charging for these services does bring in a considerable amount of income. As members will also note, some charges remain consistent from year to year and from last year, and in the main that's because they are either set at a national level, or it's deemed appropriate to leave them at that level because of the impact it may have on residents, and may well prevent them from wanting to use services. One example of services being charges being set rather at a national level is blue badges, and that charge is £10. We're consistently reviewing charging, and should any changes be required, then we would want to go out to consultation for those, as the committee have already agreed, with regards to assistive technology. When we do go out to consultation, any results of that consultation would be brought back to HOSC for consideration. I think that's the report. Thank you, Chair. If anyone has any questions.
I'll open up to the rest of the committee first of all. Does anyone have any questions? Councillor Pothcoe.
Thank you, Chair. Thank you, Catherine, for the report. I just wanted to double check that I'd read it right, but we are still giving, my first question is, we are still giving 2 hours free internet access a day to library members. I think I read that correctly. So that's really brilliant. Thank you for confirming that, Catherine. So that's really crucial, because we know that so many people depend on being able to go to the library to use a desktop PC, etc. And if you go down to Gray's Library on a weekday, it's free, and you go up to that second floor with the PCs around the balcony, they're always full of people studying and really busy doing the things that obviously they need to do to maintain digital connectedness in a society that now expects you to have pretty much internet on tap and the hardware to access it. So that's really encouraging. I do want to ask a question which is slightly maybe higher level than these individual charging prices, but is there any, we've been talking for decade and a half at least, about adult social care, about putting it on a funding model that has some kind of parity with health funding. Obviously, we've got huge discrepancies between what you're paying, you know, between your care if you have dementia versus your care if you have cancer, for example. Do we have any, you know, governments keep telling us we're gonna sort this out, are we any further in understanding quite how that's going to happen, how it's going to look? Has any progress, do we know if any progress has been made at the national level to actually try and sort this out?
I'm not aware that any progress has been made, councillor, but I could certainly check that for you and would be happy to give an update and information. It's an area that, you know, causes constant concern, and you're quite right. But it is a very difficult area, I think, to address. But I will check that, and I will come back to you with any information that I find if anything has progressed.
That's lovely, thank you.
Any other questions? Councillor.
Thank you, Chair. We are looking at approving a consultation. We're not actually agreeing these charges, or we're not. This is not us saying to Cabinet, we approve these charges. This is us agreeing to go out to consultation. Is that correct?
That is the guidance on the report, yes.
And they'd come back to us with the results of the consultation before it goes to Cabinet?
Yes.
Perfect.
Yeah. I'm correct there, aren't I, Catherine? I don't want to overstep my line there.
I don't think there is anything within the report that we at this stage would need to consult on. We've brought the one thing that we do, which is assistive technology. Everything else, the increase in residential charges, each individual would be individually financially assessed for that. So we wouldn't need to consult on that. It is just a point in the report. Should we need to go out, we will come back to you. But for these charges, I don't think there is, that are outlined for adult social care here in Appendix 1, there isn't a need to consult, because nothing has increased apart from domiciliary care, and we've already done that, and we did a consultation. It's very unusual, but we have actually got a year here where there is nothing to consult on apart from the assistive technology, which we thought was wise to bring as a separate report. But should we need to, it would always come back to HOSC before it went to Cabinet.
I just confused over the wording of the Health, Wellbeing Overview Scrutiny Committee note and agree that a consultation should be completed for the proposal of advisory fees and charges for social care and libraries. I think you've done yourself by the wording of the report, by what we're needed. I don't know where we can move on that. I don't, without having legal advice, we can only agree for this can go out to consultation. We can't agree for this to go any further.
Yes, so I completely agree. So I will go back to Kelly and the team who put the report together, and then we will come back to you. But you can, yes, you're quite right. You can only agree the recommendations as they are detailed in the report this evening.
Yeah, thank you. Thank you, Catherine, for your report. Thank you. We are now on. I do apologise. Item 13. So it was because you was item 13. That's what it was. Service harmonisation of Mid and South Essex ICB. I understand Peter Scalding and Claire Hankey. Dr. Ronald Felton are here this evening to present the item. Thank you.
Thank you, Chair, and thank you, colleagues. And I admire your perseverance and your ability to deal with it.
Are you able to put the slides up, Jenny, or shall I? Oh. I sent them to you yesterday. No, that's okay. I'll join the meeting and I can put them up. I think it bounced back and I sent you a note because it had the word sperm in it. Your firewall blocked it.
Yes, a useful health warning for what's about to follow. That there could be some words.
I think it's to you and Kerry, but it bounced back from both, so I then did just send a note on its own, but let me just join the meeting, bear with.
Thank you, Claire.
Claire, I can share if that would help. I've got them up here.
Oh, actually,
That
Pete,
might be easier because you're actually on the meeting, aren't you?
Yeah.
Great, thank you.
Pete has it there. Lovely, thank you. So, thank you, colleagues, and for your perseverance. So we're here tonight to cite you on a public consultation process that we have just begun, to hear your views on that process, and also to present you with some background information around why we have gone to public consultation, and of course we will come back to you with the result of that consultation. Pete, are you able to, that's as big as it gets. Okay, so you can see the agenda we have, we intend, I will deal with the first 3 items on the agenda, and my colleague Dr. Peter Scolding, the dashing young man up there in the left-hand corner with the poppy in his lapel, will deal with the impacts of the proposals on residents of Thurrock in particular. Peter and I have worked together on this since last February, and he's very much a subject matter expert in that area. And then, of course, the actual consultation process will be described by Claire, and then, of course, we will take questions and comments. Just moving on to the reason we're doing this, as an ICB, as an integrated care board, we have a statutory obligation to ensure that there's equity of service provision across the system. So we have a legal obligation to do that, and of course I'm sure you will agree that it is the right thing to do in any case. And the next slide points out that when we took over from the 5 CCGs in July, most, if not all, policies were aligned, except for 6. There were 6 services that varied in how they were provided by the previous CCGs. So there was a difference in provision. We knew about this ahead of time, which is why we started working on this last February. And the next slide will describe what those 6 services are. The first service is what's called bariatric surgery. This is surgery to help patients lose weight. It's not something that one is offered immediately. It's at the end of a long process, but it's part of a weight management program. You may be aware of the term gastric bands, for example. That's that sort of thing. That's what bariatric surgery is. The next thing is the policy has to do with breast asymmetry, and this is the surgical revision, usually meaning the reduction in size of breast size to create evenness of breast size, and this is for patients who have asymmetrical breasts due to genetic and sometimes traumatic issues that are impacting on their lives. Breast reduction surgery is for patients, female patients who have excessive breast tissue, and that involves surgical removal of breast tissue. Female sterilization is the blocking of the tube which carries the egg from the ovary to the uterus. You may be familiar with the term tubal ligation. That is what female sterilization is, and it's usually carried out under general anesthetic. People are asleep for that. Male sterilization involves cutting the tube that brings the sperm from the testes, and that can be carried out under local anesthetic or general anesthetic. And that brings us on to tertiary fertility services, and we've got a slide just to explain what these are. These involve a number of services. IUI, which is intrauterine insemination, basically physically putting sperm into the uterus. That's what that is. Oocyte and sperm donation, that is the harvesting of sperm or eggs for future use in various situations. You will probably be aware of the term in vitro fertilization, which essentially is putting eggs and sperm together outside of the uterus. And sometimes, because the sperm have motility and mobility issues, what's called ICSI, intracytoplasmic sperm injection, occurs, and that is the injection of sperm directly into eggs. I thought it was worth actually spelling out what those terms are. I hope that was helpful for you. So those are the 6 services that currently differ across our system simply because there were different policies in place by our previous CCGs. And these type of services are provided by the NHS in certain circumstances, and there are 2 terms that it's probably helpful to cite you on. This type of service is provided sometimes by what's called group prior approval. That means that for a group of patients, there is an agreement that if they exhibit the following issues, any patient with those can have the treatment. An example might be cataract surgery. For example, if I went to my GP or to an optician and my sight was less than 6/12 and I had various information given to me, they could refer me for cataract surgery, and that has been agreed already. Individual prior approval is slightly more robust examination on an individual basis. An example of this that you may be aware of is tonsillectomy. When I was a kid, everybody had their tonsils out. They don't now. It's because we have realized that it's not necessary. So it's an example of where I might go with my child to a GP or another practitioner worried that they need tonsillectomy. It might be felt that that is the case, and it undergoes another level of scrutiny in order to make sure that it is indeed in line with the policy. That's what individual prior approval is. So they are levels of scrutiny of the request for a service. I just thought it's important because you will hear later on those 2 terms being used. And there's a question.
Sorry, could
Yes.
I just ask
Yes.
you, because in this we've got GPA, that was really helpful, thank you. So in this we have a mixture of GPA, IPA, not funded, which speaks for itself, and then routinely funded. What would be the difference between routinely funded and either GPA or IPA?
A routinely funded thing would be a process that you hadn't was agreed to have. There was no need to go through a threshold to have it. It was agreed. You just go in and you have whatever that surgery is. I'm trying to think of an example. So, for example, any emergency surgery is routinely funded. My child goes in with an appendicitis. No one says, let's go through the following criteria. It's just going to happen. Is that helpful?
Yes, thank you. That's lovely.
Thank you. So those are just the 2 things that you'll hear spoken about in the next presentation. And I'll hand over to Peter, who will go through each of the 6 and try and highlight what the changes mean for the residents of Thurrock. Peter.
Thanks, Ronan. So I'd take them policy by policy, and for the sake of time, just on the slides, focusing on what the change would be for residents. So bariatric surgery to start here. So essentially the change would, there wouldn't be a significant change. The proposals, the thresholds that are within the consultation documents are those which are currently in effect. So the change overall across Mid and South Essex is that everybody else would adopt those criteria, and they're consistent with the national recommendations, and that would stay within a process of group prior approval. For breast asymmetry correction surgery, probably the notable change to flag would be that as part of being in that population that we would provide that surgery for, the patients must be a non-smoker. Other criteria are going to remain the same. For instance, there must be a difference of 2 cup sizes between the 2 breasts, and prior to considering surgery, steps short of surgery would have to have been kind of fully explored. And that, again, that would stay within a process of individual prior approval. breast reduction surgery. So the first change is in terms of the BMI threshold. So moving from a threshold of less than 25, so only eligible for breast reduction surgery if your BMI is 25 or less. That was the current Thurrock CCG policy. In the consultation document, the proposal would be to increase that to 27. So, 27 and less, then you'd be eligible under the new criteria. It would increase the amount of tissue that's removed during surgery from 500 to a minimum of a kilogram overall. And the same as breast asymmetry, a requirement that the patient must be a non-smoker. And again, sticking with the same process as was in place previously, that process of individual prior approval. For female sterilisation, so current policy that's in place, there's no restriction on BMI, and so the new, that's in the criteria that's being proposed, a BMI threshold of under 35 would be in place. Currently, it's routinely funded, and the proposal is that becomes group prior approval. And within the criteria, again, there's a clarification to ensure that in people who have potentially impaired capacity, decision-making capacity, to ensure that they have the full support and help that might be needed so that they can make a decision about what's appropriate for them. Male sterilisation, so I think Rhoda mentioned, potentially that can happen under local anaesthetic or in a much smaller kind of subset of cases under general anaesthetic, so people are asleep. For local anaesthetic, previously that was within a process of group prior approval, and it's proposed that that becomes now routinely provided. And under general anaesthetic, that stays the same in terms of those threshold criteria and the process under group prior approval. And then finally, for specialist fertility services, so a few changes to talk through. So firstly, expanding the access to IVF in terms of the number of cycles for two groups. So firstly, prospective parents between the ages of 40 to 42. So currently, there's no funded access within the health service for prospective parents in that age group. So the proposal is to increase that to be able to access one cycle of IVF. And then the second group is for same-sex couples, and currently within the current policy they have access to a reduced number of IVF cycles, and the proposal would be to bring that in line with heterosexual couples, so that there's no kind of distinction. Secondly, under the new proposals within the document, intrauterine insemination wouldn't be provided either for heterosexual or for same-sex couples. The current policy includes provision, some limited provision for heterosexual couples, so that would be a change. And in terms of egg donation, small change maybe, but one batch of eggs is currently funded. The definition of that would change so that from 5 eggs making up one batch to 6, so some slightly increased access there. No change to sperm donation, and that continues to be within a process of individual prior approval. And then my last slide, I think. So overall, the process to date to exploring and developing these proposals has taken into account significant level of clinical input, and happy to talk more about what that's consisted of, the views of local people, and Claire will go into that, and whilst at the same time ensuring that equity and affordability of our local NHS services. We didn't propose within the consultation document to continue our current kind of pattern of providing services, because that varies between the different places within Mid and South Essex, and so continuing would perpetuate that variation and inequality. So that's why that's not an option within the document. So I'll pass over at this point, if I may, to Claire.
Sorry, could you... I've got a bit of feedback there, I don't know why.
Might be from your...
Might be from my laptop, yeah. Thanks, Pete. So I just wanted to kind of run through you the consultation process, which we're bringing before you tonight. So we actually launched on Monday and couldn't quite align the HOSC meeting with the start of the consultation. We would have ideally liked to have come to you before, but I do know we did brief the chair prior to kind of going out to consultation. So we launched on October, and this is an opportunity for us to gain a wider spectrum of views. We're running a survey both in print and online, which has been promoted through the local media, social media and various other outlets, and through our kind of partners, particularly our partners in Health Watch and the CVSs. And we've also placed the consultation document and paper copies of the survey into our local libraries across Mid and South Essex, and thank you very much to Thurrock Library Services for their support in doing that. We've worked with a number of residents group to help promote face-to-face and on Facebook to get the word out about the consultation. We're holding a series of events across the consultation period, which runs up until the 19th of December, and that includes an event in Thurrock which takes place next week at the Beehive, which is an opportunity for people to come and talk a bit more in detail, and Dr Fenton and Dr Scolding will be there to answer any questions from members of the public about the policies and the proposals. And then we're also arranging a series of focus groups with those groups more likely to be impacted by some of the things that we're talking about. So in particular, if you look at IVF services, we know same-sex and LGBT couples often face greater inequalities in the provision of those services, so we'll spend some time really understanding kind of the issues from their point of view, and also reaching out into those communities that often don't participate in statutory consultations. And then we are providing as you would expect, the consultation document in an easy read format, and also other formats available on request. Next slide, please, Pete. So we had a pre-consultation engagement that helped us to develop the proposals, and that included a survey that went out, as well as some conversations with those already having taken part in the services, already having experienced the services, to understand what it was about those services. And some of the things that particularly came out about that was that need for equity. People didn't want that so-called postcode lottery across Mid and South Essex in terms of the provision of these services. But there was real recognition that obviously we have to balance this in the consideration of providing other NHS services across the patch. So there was that understanding of the financial impact of these services. As I said before, the consultation runs through till the 19th of December. The consultation feedback will then be independently analysed for us, and a report will be produced in January of next year. I can't believe we're talking about 2023 already. And then that will form part of the decision-making process that goes to the Integrated Care Board for discussion around whether we adopt the proposed policies or make changes to them as a result of the work that's gone on over this period. And that's due to take place on the 9th of February. So, and then any changes that take place would then take effect from April next year. I think that's us. I think it's just for questions. Thank you, Chair.
Yeah, thank you. First of all, on page 113 on our agenda, it's got a proposal for a consultation. This is under the IVF section. It's got smoking. Couples must be non-smoking at the time of treatment. Are we asking people to start smoking so they can get treatment? Is that a typo?
I think it must be, yes.
Can you just double check that on there? Because it does say couples must be non-smoking at the time. No, the couples must not be non-smoking at the time of treatment?
Must not be smokers at the time of treatment. That is a definite typo.
Just double check that one, because that's a bit of a faux pas. I just want to double check, obviously, when we come to things like the breast reductions and IVS, these are people's lives, these are their dreams and their hopes. And it's quite a sensitive issue. I know before in HOS, where we've looked at either increasing or decreasing the amount of tries they have and access to the IVF system. I just want to double check, we've always offered 2 free shots of IVF, haven't we, within Thurrock?
Pete can answer that.
Yeah, Peter, yeah.
Yeah, so I believe the policy was, yes, within an age bracket, so 23 to 39, 2 cycles of IVF. Above, 40 and above, it wasn't funded previously. And then same-sex couples had a maximum of 1 cycle that was provided previously.
Brilliant, thank you for clearing that up. Going open to the questions, it was Councillor, Kim James first.
Claire, Health Watch and CVS are in the beehive, as is Gina. We knew nothing that you had any kind of an event running there. We've promoted the paperwork that came out to promote it. We've got that out on our social media and everything, but we are not advertising the event because we knew nothing about it.
I'll check back on that then, Kim, because I wonder who we've booked it with then. Because
well, you've booked it with our bookings, but they wouldn't tell us that you're what it is.
Okay.
Just that there's a booking. Right. What I'm saying is, obviously, I don't know how you've got the word out that you're running a public event and who to.
I mean, it says on all the documentation that's gone out, and it has gone out to the local media and everything as well. But I'll come back to you on that, Kim, as to why we didn't let you know specifically that event was happening. I do apologise.
We could have pushed it for you if we'd known.
Thank you. Councillor Puffkerry.
Thank you. Mine was just a really quick question and a comment on how, stingy Mid-Essex seems to have been. But as they seem to be the main beneficiaries of this, obviously, it is crazy that you can't get the same type of care and access to services, and it's a horrible sort of postcode lottery. And as the chair said, a lot of these are really important things for people's lives. So I do welcome the report. I did have one question though, which was, and it is one of the changes that's going to be made to our policies essentially, which is that at the moment it sounds like the asymmetrical breast treatment and the breast reduction are open to smokers, and this policy would take that opportunity away from smokers. I'm just wondering what the clinical justification for that is.
So the clinical justification for that, just to take you through the process we've gone through to date, we have put all of these services through our clinical multi-professional group, which is a 15 cross-system group. We've also then convened specialist groups for each of the clinical conditions, specialists in that area for their view on the thresholds that will be placed. The view of the groups, the specialist groups in the area of breast reduction and asymmetry about smoking, related to their view of the impact on smoking on healing of the relatively large wounds that are involved in breast reduction surgery. That was the issue. It was their view that the benefit of people stopping smoking would be important in the outcome from that surgery. But however, we're actually really open to people asking these questions. Similarly with the fertility treatment, the issue with smoking there was that it impacts on fertility and conception.
Yeah, thank you for that. I think it might be worth in the consultation, because it does say you do have an explanatory note in the IVF section on smoking, but the other one, I wouldn't have known that. I wouldn't have made that connection. So I just wanted to double check that we weren't just penalising people because we don't want people to smoke. So, we're not going to give you this service because you smoke. So I think it might be worth, if when you're doing the consultation, you make it clear that there is a clinical justification for that and we're not just being nasty to smokers.
Yeah, I was going to sum up with the similar question, but it was also, what was the time frame of becoming a smoker to a non-smoker? Is it 6 months? Is it a year?
Thank you, and that is something that came up as we have gone around just preliminary discussions. We and Peter and I discussed this yesterday. We've got to come up with what actually means that you're not smoking. I don't have that definition, but we will have.
Joe Broadbent.
Thanks. Just a question on the fertility policy. I think what you said was that you were going to continue to fund IVF for those who met the criteria, but that you won't be funding IUI. Was that correct? So is one of the criteria for getting funded IVF to have been through a certain number of IUI cycles previously? Because it often is.
Yes, you have to demonstrate infertility. Pete will correct me. I think it's 2 years of trying, or Pete, you'll have the actual detail.
Yeah, exactly, Ronan. So, Joe, the principle is one of the principles to kind of qualify for IVF is demonstrating infertility. For male and female couple, it's a period of 2 years. Of sex without conceiving is taken as unexplained infertility. So, and that's that requirement. So there's in male-female couples, there's no requirement to go through any process of IUI. For a same-sex couple, obviously they're not able to demonstrate infertility in the same way, and so the requirement in terms of demonstrating infertility has been 6 cycles of IUI. That's not been funded previously under the CCG policy, and so that part is staying consistent. So hopefully that answers the question. Apologies, I can't hear you.
Then that would create an inequity, but you're not saying that, so that's good.
No, just to be clear, it is the case currently that that IUI is not funded for same-sex couples currently. That doesn't change in this new policy, but it does mean that same-sex couples do need to fund their own IUI in order to demonstrate infertility. And this is a really good question, because what it brings out is the discussion and the richness of discussion that we've had to have, and we are grateful for the challenge on this as well, because it was the view of the expert panel on this that in terms of the funding that you have, the opportunity to actually realise the best benefit for that was not in IUI, it was in vitro fertilisation. That the actual likelihood of getting most success for the funding, and those are the decisions that we have to encounter now. So you are right, Joan, you make a really good point, thank you. And that was the basis for the decision.
Go on.
Thank you, sorry. So how much is a round of privately, roughly, approximately, a private round of IUI?
I don't know. I'm hoping Pete might, but he probably doesn't either. We'll get that information for you. Thank you. It's a good point.
Because 6 rounds sounds like, if that's £2,000 a round.
Around.
I think it's around £600, only because I know somebody in the team that has been doing something similar.
Yeah.
Okay, thank you.
So it's not insubstantial. Thank you.
Okay, thank you. So we are asked to, sorry, Councillor Piccolo, sorry, I do, sorry.
So yeah, just quickly, on the non-smoking, how long does someone have to have been a non-smoker prior to getting the treatment, and how do you check on that? And as more importantly, and as importantly, how do you check that they remain a non-smoker in the vital months after?
Thanks for the question. It is the second time we've had it, and the answer is it is only through these sort of discussions that has been highlighted. We will define that, and thank you. That's the purpose of this consultation as well. That we haven't got that information. We hadn't thought about that element, I think, until yesterday, Pete, when one of our colleagues pointed out exactly the same issue. We will get on to that, and we will alert you what definition we put around that, because clearly it's important. Thank you.
So on that note, does vaping class as smoking?
Certainly, nicotine would, the inhalation of nicotine, and I'm now talking freely. I would imagine the inhalation of nicotine would, but we'll define that as well. Thank you. These are all very helpful things. Thank you.
Because surely it would be the inhalation of carbon dioxide and the other chemicals that would reduce the healing process and not the nicotine itself. Because nicotine is just an addiction and not the actual chemicals that are inside the cigarette. I see Pete is shaking his head.
Yeah, I just think it's a really good question. So I don't think we do have the answer off pat. And so thank you for the question. We'll look into the evidence base for that. But
Okay, thank you. So we are noted the update and agreed to receive an analysis of the consultation of further meeting. And please, could you join up with Kim James and sort out that situation? Give him the thumbs up. Thank you. Okay, item 14, this is the work programme. We'll find it at the end of the evening. Thank you all for your patience. Just a couple of things to add to the work programme. Do you know what? I did in my head we had another meeting in December, but we don't. It's just January, isn't it? We go to January now. We have an urgent item coming up that we'd like to call in EPUT due to the Channel 4 documentary on the mental health support. That was the documentary went out on Channel 4, and I have to declare an interest because I am Thurrock Council's governor on EPUT. So on that, when we call it in for the January meeting, Councillor Piccolo will chair that section of the meeting for that. Also, I mean, I am our rep on it, and that's why I'm calling them in there, because it was quite a damning television programme. It was very upsetting. So it's just for them to offer us an update on that. Councillor Fish.
Well, yeah, just to say that I used to be Cat Thurrock's representative on the same organisation, and there were issues then as well. So it's a long-standing issue.
Yeah, totally agree, and it's a long time coming, unfortunately. And it's a sad situation. Now, I do know that we've also bring on air quality to the work programme. I am now aware that the Cleaner Greener group published a report yesterday, which really had some great work on there about the air quality. I don't know if you feel we still need to bring it on here. I know it's a question that that you raised.
If somebody somewhere in this council could tell me what the plan is about air quality, I don't mind where they tell me, just as long as they tell me.
Yeah, I'll say he's now on the news site from last. Do you know what? I only see it earlier because we was going to ask for the report to come here with some detailed breakdown. But now seeing that the Cleaner Greener group have just published a report, I think it might be that we look towards them for it.
I think looking at how heavy the agenda is over the next 2 meetings, I think, yeah, that would be sensible.
Okay, thank you all for your patience. This concludes the business of the meeting tonight. I now declare the meeting closed at 8 minutes past 10. Thank you.